Reid. In our first session this morning, we are meeting with the Minister. In our first session this morning, we are meeting with Minister Simon Harris, TD Minister for Health, and his officials, and Ms Laura McGahey, the recently appointed Executive Director of Sláintecare, in relation to the Sláintecare strategy. On behalf of the committee, I would like to welcome you, Minister, and Ms McGahey to the committee. I wish to draw your attention to the fact that by virtue of Section 17(2)(l) of the Defamation Act 2009, witnesses are protected by absolute privilege in relation to the evidence they give to this committee. However, if you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to qualified privilege in respect of your evidence. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any person, persons or entity by name or in such a way as to make him or her identifiable. I also wish to advise you that any opening statements you have made to the committee may be published on the committee's website after the meeting. Members are reminded of the long-standing parliamentary practice to the effect that they should not comment on, criticise or make charges against a person outside of the Houses or an official either by name or in such a way as to make him or her identifiable. Could I now ask you, Minister, to make your opening statement, please? Thank you.
Thank you very much, Chairman. Good morning. And I'd like to thank the Oireachtas Health Committee for inviting me to attend today to discuss the implementation of Sláintecare with you. And I'm very pleased to be joined by Laura McGahey, who was recently appointed as Executive Director of the Sláintecare Programme Office. Laura was appointed following a comprehensive recruitment process and brings a wealth of experience to the role. And I want to formally welcome her to the position and assure her of my full support in this challenging but exciting role. Laura took up post officially on the 1st of September and has very much hit the ground running since then. And shortly I'll ask Laura to outline her immediate plans for implementation and progress to date. Just as the Government and I value the cross-party support that produced the Sláintecare report, we recognise that the same support and cross-party cooperation will be required to successfully deliver the Sláintecare implementation strategy. I think every party and grouping in the Oireachtas, perhaps bar one, has said they're in favour of Sláintecare and they're in favour of the implementation of Sláintecare, which is very encouraging. I suppose we do all need to work together now to make that a reality. As I've said here before, we will only succeed in bringing about change if everyone, politicians, clinicians, patients, service users and others, are united on the overall goal and we're all pulling in the same direction. The publication of the Sláintecare implementation strategy in August marked another important step in this process. The strategy provides an implementation framework for the transformation process, and it outlines 106 specific actions that will be taken over the next 3 years, the first 3 years of the strategy. I firmly believe that this process is different to others that came before it, because this is not my plan and it's not just the government's plan. This is the long-term plan. It is the only plan. It is everyone's plan. Change of this magnitude cannot be delivered overnight, and it's important that we acknowledge this is a strategy that will take time to implement. The publication of the strategy was an important step, but this is a process that will have many steps over its lifetime. We've also paid particular attention to getting the implementation, governance and structures right, which I know was rightly important to the Committee on the Future of Healthcare. In the past, this has been lacking. We've had many strategies before. It's been a lack of an implementation structure that's often caused the challenges, and I will return to this later. Finally, Chair, we are committing to the development of detailed action plans each year, and we will measure our progress transparently with twice-yearly progress reports. This is a new departure in terms of health reform, and we're trying to use a model that's been used, say, for example, in the Action Plan for Jobs model, where you don't just say you're going to do something, you say you're going to do it and then you report against it. So every 6 months we will publish a progress report to show this is what we said we were going to do, this is who we said was going to do it, is it done? If it is, great, and if it isn't, why is it not? I think that transparency in terms of reform is something that quite frankly has been lacking in our health service over many years, and it's a focus I hope we can bring to it. The Sláintecare report will be delivered over a 10-year period, and at its core it will do a number of things. It will move our system to a population-based approach of healthcare planning and delivery, and this will involve the development of a citizen care master plan for the health service. This will inform service planning, resource allocation, workforce planning and policy prioritisation. This is really important. In the past we've tried to develop the health service to suit the health service, the system for the system. What we're actually trying to do now is find out what services do our citizens need, what is the Citizens Care Master Plan, and then put the structures around that, not the other way around. Informed by this framework, new models of care will be designed that are structured, coherent and tailored to population need. It will continue the focus on promoting the health and well-being of our population through the implementation of Healthy Ireland, the framework for improved health and well-being. And a priority action is the publication of the Healthy Ireland Outcome Framework this year. A huge part of Sláintecare, in fact at the very core of Sláintecare, will be the focus of bringing the majority of care into the community. This will require a much stronger system of community care with increased resources and an expansion in the range of services that are available. The initial focus will be on developing capacity to manage chronic disease in the community, development of community intervention teams, we've made some progress on that, increasing investment in and access to community-based diagnostic facilities, and the development of community nursing services. We will also move towards a health service where care is provided on the basis of need and not on the ability to pay. This ambition must be planned carefully and must be introduced over a time period that is appropriate in terms of making sure we have the workforce and the investment in place. If you don't get this right, if you get the sequencing of this wrong, all you actually do is end up rationing care in the community rather than ensuring people can access it. Progress is being made in extending entitlement, including providing medical cards to those in receipt of domiciliary care allowance and GP visit cards to those in receipt of carers allowance. The government is also committed to the introduction of a statutory scheme for home care to support people to live in their own homes, and it is my intention that this scheme will be operational within this first 3-year period of the strategy that we're discussing specifically today. Under Sláintecare, we will move our system from long hospital waiting times to a timely service, especially for those who need it. There is no single solution to this, but additional bed capacity both in the hospitals and the community is a big part of it, along with investing further in home care services, multi-annual plans for reducing waiting times, and considering how best to introduce a waiting time guarantee. One development that I believe will be significant, and indeed the Sláintecare report talks about, is the development of elective hospitals. We have funding to deliver 3 elective hospitals, one in Dublin, one in Cork and one in Galway. I had the opportunity last week with Laura McGahey to visit the Golden Jubilee Hospital in Glasgow in Scotland to see exactly how they developed an elective-only hospital. And the good news is they have managed to significantly reduce their waiting lists. When that hospital first opened, people were waiting 3 years for a hip or a knee replacement. They now have that down to 12 weeks. When the hospital first opened, people were waiting 2.5 years for a cataract. They now have that down to an average of 4 weeks. So we now must move on with the development of our elective facilities. We've seen it's worked in Scotland. We now need to produce that model here as well. We're going to pick the sites for these 3 hospitals next year, and our focus is always on driving down waiting lists and ensuring patients can have access to services as soon as possible. Sláintecare will also bring about improved governance, performance and accountability, something this committee spends a lot of time talking about for very good reason and scrutinising. This will be achieved through the establishment of a HSE board, defining new organisational and operational structures for the future reconfiguration of the health services. The HSE board legislation will be introduced in the Seanad next week on the 10th of October, and I hope with everyone's cooperation here to pass it through both houses of the Oireachtas this year so that it can take office at the beginning of next year. I was pleased to announce Ciarán Devan as Chair Designate of the new HSE Board. Mr Devan brings a wealth of experience to what would be a very challenging role, and I look forward to him having an opportunity to come before your committee, Chairman, to be scrutinised on his views and plans in relation to that role. I've already mentioned the importance of implementation, governance and structures, and I would like to briefly outline a number of key elements. There's widespread agreement that significant change and reform requires a well-resourced programme office to champion, lead and manage the process. The Sláintecare report recommended the establishment of such an office, and a Sláintecare programme office has now been established. It will be led by Laura, and it is being resourced with the skills and expertise necessary to lead the reform programme. The programme office is, as I said in August, working on a detailed action plan which will be published before the end of the year. This will include a review of all the actions and the associated timeframes, the development of detailed milestones and, crucially, the assignment of responsibility for each action. In the Sláintecare report produced by the committee, it did ask that when we publish the plan, that plan would then be reviewed by the Executive Director, and that's the process that we're now undertaking and published by the end of the year. There are 2 other structures which I wish to draw your attention to briefly this morning, Chairman. The first is the Sláintecare Advisory Council. I think it's really important that we get stakeholders involved and that we ask experts here to help us out in the delivery of this plan, because this plan can't be something just owned in the Oireachtas or in the HSE. So I'm very eager that an advisory council would be in place. I'm delighted that it will be chaired by Dr. Tom Keane, a very eminent clinician and clinical leader who came to our country and worked with my predecessors and previous governments to reform our cancer services, and we're seeing the benefit of those outcomes today. I'm delighted that Tom has agreed to lend his services to Ireland again. and Tom will chair the Advisory Council. It will comprise of 23 members, and this morning I was pleased to be in a position to announce the membership of the Council. And for the record of the committee, that the membership is Professor Tom Keane, the former Director of the National Cancer Control Programme, Laura McGahey, the Executive Director, Siobhan Kennelly, a Consultant Geriatrician, Anthony O'Connor, a Consultant Gastroenterologist, Paddy Brough, a General Surgeon in Beaumont and Clinical Director in the RCSI Group, Colm Henry, the Chief Clinical Officer in the HSE, Annette Kennedy, the President of the International Council of Nurses, Dr Ronan Fawcett, a GP in Kilkenny who's really done some excellent work in terms of the development of primary care, Gillian O'Brien, the Director of Clinical Governance in Jigsaw, Roisin Malloy, an incredible patient advocate with a wealth of experience in this area, Brendan Courtney, a patient advocate who really shone a spotlight on the importance of getting home care right in this country and looking after our older citizens, Sarah O'Connor, the CEO of the Asthma Society, Brian Fitzgerald, the former CEO of St James's Hospital and Deputy CEO of The Beacon, Liam Doran, the former General Secretary of the INMO, Leo Kearns, the CEO of the RCPI, Joseph Figueres, who I believe would have spoken at the Committee on the Future of Healthcare and is a Director of the European Observatory, Joanne Shear, the former National Primary Care Clinical Programme Manager of the US Veterans Health Administration, Heather Shearer, a clinical governance expert, Eddie Malloy, a management consultant, Paul Reid, the CEO of Fingal County Council, who I think brings a wealth of experience in change management, Professor Mary Higgins, an obstetrician in the National Maternity Hospital, Dr Anna McHugh, a GP registrar in Donegal, and Dr Emily O'Connor, the President of the Irish Association of Emergency Management and a consultant in emergency medicine at Connolly Hospital. So you have 23 members of the committee, almost gender balanced, a split of 12 to 11, and a wide range of skill sets there, both from a patient advocacy point of view, from a change management point of view, and also from a medical point of view, which is so important as well. So I really want to thank those people for stepping up and serving, offering us their wealth of experience. The first meeting of the Advisory Council will take place and be chaired by Dr Keane on the 24th of October, and I hope this committee will at some point have an opportunity to engage with Professor Keane on his role and how he envisages the Advisory Council helping us deliver. So the second structure, and I'll pick up my speed here, Chairman, is the High-Level Delivery Board. This will be made up of the Secretaries General of the Department of the Taoiseach, the Department of Public Expenditure Reform and the Department of Health, the Director General of the HSE and the Sláintecare Executive Director. This is really important. The Committee on the Future of Healthcare said to everybody that you wanted a whole of government approach to this, and I think having a high-level delivery board that the Executive Director can feed into and that can then feed into the Cabinet Committee on Health chaired by the Taoiseach is absolutely crucial, and having in the room the Secretaries General of the Department of Taoiseach, the Department of Health and the Department of Public Expenditure and Reform I think is really important, and it's very much in line with the Committee's strong recommendation on the need for cross-government support. So we have begun progressing a number of recommendations already. As I've said, we moved ahead with the establishment of the HSE board. We'll have that legislation commencing in the Shannon next week. As I say, I'd really appreciate cooperation in relation to that. Crucially, we've carried out a public consultation on the geo-alignment of hospital groups and community health organisations. This is now being completed. I'll publish the results shortly. And let me say this, I want to move ahead with outlining what geo-alignment will look like this year. And I'll need your support on this. Drawing lines on maps is never the easiest thing for any politician to do. The Sláintecare Committee very helpfully left it to my department to work out how best to divide up the country. But what the Sláintecare Committee was very, very keen on, and what I'm very, very keen on, is that we move away from this siloed approach that you have duplicate management structures for the community care and the hospital care. If we are to deliver Sláintecare, we need geo-alignment. We need a singular budget for a certain geographic part of the country to deliver the whole spectrum of care. That's what we need to get to. I've taken the decision, in consultation with Laura McGahey, to move forward on that at a quicker pace than originally envisaged, and I intend to announce my proposed geo-alignment this year. I think this is the potential game changer that you want to see in terms of Sláintecare, because you can no longer have siloed budgets. Somebody saying, oh, patient X needs to remain in the hospital because it will cost me money to care for them in the community, or vice versa. One budget with a board for each regional entity, holding people to account at a regional level, I think is really a very important way. It will help deliver integrated care, but I will need your support. If we are to legislate for this, I will need the support, the cross-party support, in terms of delivering that. And I'd be very happy, Chairman, Chairman, to discuss with this committee the public consultation document in advance of that, or indeed to send that to this committee so you could consider it, and I'd very much welcome, in the spirit of bipartisanship, your commitment, your consultation rather. The Committee on the Future of Healthcare also was very clear in relation to the role of private practice in public hospitals. And let me be clear, because sometimes I hear myself described by my opponents wrongly in relation to this. I am in favour of the removal of private practice from public hospitals. But, like the Sláintecare Committee, I'm in favour of doing it in an intelligent, phased way. I've made my views on this very clear. I believe our current mixed model system is an outlier. We cannot convince ourselves it is the norm. It is not the norm. It is an outlier in that in a public hospital, you can have a public hospital full to capacity and a patient who is in greater need of care not getting that care because somebody is carrying out private practice in that hospital. We can't stand over that. But we also have to do it right. And we can't do it overnight. So the committee asked me to set up an independent review group. I've done that. It's being chaired by Dr. Donnelly to examine the impact of separating private practice from the public hospital system. The work is ongoing. I expect to receive that report by the end of this year or shortly thereafter. And this will then provide valuable guidance, which I'd welcome a chance to discuss with this committee. But my policy objective is clear. I believe we need to remove private practice from public hospitals, but we need to do it in a way that makes sense. I want to just briefly talk about the role general practice needs to play in relation to this. We cannot deliver a decisive shift to primary care or community care or more services if we don't resource general practice. You'll be pleased to know that I have reached agreement with the Minister for Public Expenditure and Reform on very significant multi-annual funding for general practice, and I expect very intensive engagement to commence on this matter in the next few short weeks. Finally, I've already mentioned capacity. We know that the Irish Health Service, even when you make reforms, it doesn't have adequate bed capacity. We do not compare favourably internationally in relation to this. We do have in our National Development Plan €10.9 billion, much of which is directed very much at Sláintecare. This will include 2,600 extra beds, the 3 elective hospitals I mentioned, and 4,500 community care beds that have already been identified. It will also include the rollout of e-health, so important and a key recommendation of Sláintecare, and putting diagnostics into our primary care centres. We have 124 primary care centres across the country now in operation. The key now is what more can they do? Can we put more X-ray facilities, more ultrasound facilities, more staff into these facilities? And I'm pleased that the development plan will deliver that. So I am confident, Chairman, that the plan that many of you in this room worked so hard on and engaged on for such a long period of time is the right plan, and that if we implement it, we'll very much be on the right track. We agreed on the vision. We now have an implementation strategy. We now have dedicated people led by Laura to actually deliver and implement this strategy. We will report twice a year. We will publish detailed annual action plans, and we will resource this through the budgetary process as well. This is going to require a broad coalition of support, and I do look forward to working with all stakeholders on the important agenda. And with your permission, Chairman, I might ask Ms McGahey to say a few words.
Yeah, Ms McGahey, you can make your opening remarks. Thank you.
Thank you, Chairman, and thank you, members. And I very much look forward to working with all of you over the next number of years to deliver on the Sláintecare objectives and indeed on the principles that were outlined in the original Oireachtas report. The robustness of the Sláintecare structure, I believe, really gives a very sound underpinning, and I suppose I'm the little circle in the middle. So the implementation office is in the middle and will be supported by the advice from the Advisory Council, which I very much welcome, reporting through to the other structures that the Minister has outlined. But I do believe it gives a strong link back through to the system and down and out to the people who are actually delivering the services. The remit of the Programme Office is to establish the programme of reform, to develop a strategic and programmatic approach to implementation, working with all parts of the system to ensure that everybody is following the strategy, and to work collaboratively with all the stakeholders, and to support the work of colleagues in the reform efforts, and indeed to report on progress. And I'm very keen that I'm not going to duplicate any effort that is around. So what I'm proposing is to have a small, tight office that then links out to the people who are doing the work, and to have a very strong focus on implementation. I'm mindful that everybody here has a part to play in the Sláintecare delivery, and I suppose key to that is the continuing political buy-in, in particular and the leadership that was shown by the cross-party Oireachtas committee, and that's so important to me in the implementation process, and I do look forward to working with you to hopefully continue to have your support. And I'm very happy to meet with you individually if you'd like to have more details on what I'm proposing, and to really encourage that involvement from yourselves in the process. Key, I do believe, though, also is citizen engagement and empowerment, and I'm beginning a programme of citizen engagement and empowerment before the end of this year, because again the buy-in of the citizens is critical to this process, as indeed is the frontline enablement, so the people delivering the services, and also the wider determinants, because we do tend to focus in health, I think, on the HSE and on those structures, but actually the wider determinants and involving them in prevention in particular for the health and well-being of people is something that I'm going to be focusing on. So very much a partnership approach. I beg your pardon, I was just going to say just a couple of points that I've done. I'm 23 days in office, so just very new really. So obviously it's a long time. Long time in politics. It's not a long time in implementing a 10-year strategy. So the office was established, and I'm very much engaged in beginning discussions with people and what's important to them, and identifying those priorities. But key in my job really is to come back before the end of December with an action plan for 2019 that says who's doing what, where, when and how. So that is my focus, and there are 106 actions in this strategy, so I'm intent on delivering when I said I would do it. The Advisory Council is established, and our first meeting is in October. And I've finalised my approach to the Citizen Care Master Plan, and as I said, the citizen engagement and empowerment process will roll out before the end of the year, and obviously the budget is under discussion at the moment. So thank you very much for the opportunity to meet you all, and look forward to working with you.
Thank you very much, Ms McGahey. So, Minister, the process we're going to engage in this morning is we're going to give each member 7 minutes to interact across the floor. So we'd like the members to be concise in their questions, and perhaps you to be concise in your answers so that we can move along speedily. So, Minister, I'd just like to ask you a number of questions to start off with. The first one is, why was the Sláintecare office not set up in the Department of the Taoiseach rather than in the Department of Health, as recommended in the Sláintecare report?
Sure.
Secondly, given the nature of building in Ireland and the nature of building hospital beds, when do you expect the first new hospital bed will be built and available? Because I understand that most of the capital resources at the moment are going into the completion of the Children's Hospital, which won't be completed until 2021 or 22. And the third question, Minister, is why in the strategic Sláintecare implementation strategy was there no reference made whatsoever to setting up of a national health fund, which was a central component of the Sláintecare recommendation on how this would be funded going into the future? Thank you.
Well, thanks very much, Chairman. So, the Department of Health versus the Department of the Taoiseach in terms of where the office should reside is something we discussed at this committee in the past, and it's something that I made my views very clear on. The Minister for Health, and indeed under Sláintecare, the Minister for Health is accountable to the Oireachtas for the delivery of the health service, subject to the Health Acts and the powers of the HSE and the functions that they have, and is also accountable democratically in terms of answering parliamentary questions, topical debates, private members' motions, legislation, and to hive off the responsibility for reform of the health service not to the Minister for Health of the day would have been a very peculiar construct in my view and the view of government under the Ministers and Secretaries Act as well. So what we did do though, and I did flag this with the Sláintecare Committee in advance of publication, I did also flag it at this committee post publication, and what we did do was though make sure that there was a structure in place to try and achieve the same objective. Whether you agree or disagree, we have done that. That's what we endeavoured to do. So by ensuring that there's a high-level delivery board that involves the three sec-gens of the three, kind of, if we call them the crucial departments, the Department of the Taoiseach, representing the Taoiseach of the day, the Department of Health, representing myself, and the Department of Public Expenditure and Reform in terms of resourcing, I think is the way to go. Also the fact that the Taoiseach will chair the Cabinet Committee on Health, where if you look at the governance structure, the Sláintecare office will report into, and Laura and indeed myself will account to the Taoiseach for. In relation to the beds, it's a very valid question that you ask. How quickly can we start delivering hospital beds? And I can more hospital beds, and I can assure you it's a question that I ask several times a week as well. I've asked the HSE to do a body of work to produce a document. How many beds could they deliver over the next 3 years using a combination of modular build, existing space in hospitals, and a degree of internal reconfiguration to make more space or to make space better used in hospitals. And they've come back with a figure of in around 600 hospital beds over the next 3 years. I can send you a detailed note, Chair, because I don't have it to hand. But the answer to your question is I believe over the next 3 years about 600 of the 2,600 beds can be delivered. A fair chunk of them towards the latter half of 2019. An area you'll be familiar with geographically and medically is obviously Limerick. So if you take the example of what do I mean in that region, and indeed Deputy Kelly very familiar with this too, I mean the delivery of the modular builds that would put 60 beds into University Hospital Limerick, which is something I'm very committed to doing and I've discussed with the hospital group CEO. So that modular build in Limerick, 60 beds, is an example of the first tranche, if you like, in that 600. In relation to the National Fund, it was decided when we were publishing the implementation plan not to make any decisions that are budgetary matters outside of the normal budgetary cycle. But we will need for the delivery of Sláintecare an integration fund. I believe there's already an awful lot of funding in the Department of Health, both now and that's likely to come through the budgetary process, that will be Sláintecare proofed. So if you look at the capital plan, there's almost 11 billion in the capital plan. My own analysis of the plan suggests that about 6.6 billion of that is Sláintecare. Be it elective only, be it diagnostics in the community, be it bed capacity in the hospitals and the community, and e-health. But above and beyond that, what I need to empower, if that's the right word, Laura and her team to do, and the Sláintecare Advisory Council to assist with, is the large-scale rollout of projects to take services from the acute into the community. And without preempting that strategy, just to give you an example of one of the kind of models that people often talk about, is the Sligo eye care model. That has been piloted now for so long, everybody accepts that it works. At what point can we actually say, let's do that? If I can take another example in Deputy Kelly's constituency of the Nina Cataract Theatre, another example of how we know it works. But if it works in Nina, can we make it national? If you take the CIT, the Community Intervention Teams, we know they work, we are rolling them out, can you roll it nationally? Sorry
to interrupt you, Minister, just to keep it moving.
Please, yeah.
Sláintecare recommended that there would be funding allocated to the plan on a yearly basis, 385 to 450 in relation to the expansion of entitlements, and a 3 million transition fund to make up for the lack of infrastructure over the last number of years. But in your implementation strategy, there's no reference to funding whatsoever. You make a reference to an integration fund.
Yeah.
There's no value put on that fund.
Correct.
So how can you give us confidence that there is going to be funding made available to implement this strategy? And I just 1 minute, and then I'm going to move to Deputy Donnelly.
So I'll give you a very straightforward answer. So it is that's an issue that will have to be addressed as part of the normal budgetary process. And when I launched the implementation plan in August, I would have made that point, that the government has decided that the resourcing of Sláintecare, which is something all political parties obviously have a role to play in a minority government's life, in terms of the resourcing of that plan, it is a matter for the estimates process. Obviously, we have our budget next week.
Thank you very much, Minister. Now, Deputy Donnelly.
Thank you, Chair. You're very welcome, Minister. And Ms McGahey, I'd like to wish you the very best of luck. You've taken on a Herculean task. Fianna Fáil signed up to Sláintecare. We helped write it, and we would like to see it implemented. Minister, healthcare reform is difficult, it's complex, it fails a lot of the time around the world. And one of the things it requires is credibility of leadership. And I am worried by some of your statement, in that you are understandably looking to the future, but there's no reflection on the problems we have right now. So, since 2011, healthcare spending has gone up every year. Total healthcare spending, it's gone up per person, and it's gone up when you adjust for inflation. And yet, waiting times across the board for men, women and children all over Ireland are worse than they've ever been. We have the third year in a row with a massive budgetary overrun, and it's fair to say that clinicians all over the country are at their wits' end. And I just want to focus on waiting times because it's the one that affects the patients most. Children with special needs are waiting 3.5 years for treatment. Young children with scoliosis are waiting 3 years for treatment. In the rest of Europe, spinal curvature isn't allowed to get past 45 degrees. In Ireland, it's past 100 degrees. There's now, for the first time ever, over 1 million people or lists. The waiting lists have gone over 1 million. When you add the NTPF figures with all of the other figures, we're at 1 million. We've never seen this happen before. And in spite of annual increases in funding, it's getting worse and worse. So if we take the number of people waiting for surgery over a year, in 2010 it was about 700, it was just over 700, and now it's 14,000. So for every one person in Ireland who was waiting over a year for surgery in 2010, for every one of them there's now 20, which goes to the heart of credibility. And my real fear is that these failures and the responsibility to fix these things are now being put on Sláintecare. The presentation lists 7 Sláintecare objectives. I won't read through them all, but I would put it to you that 4 of these objectives should have nothing to do with Sláintecare. They're just the job of government. Promote the health of our population. That's just normal health care. Move our system from long waiting times to a timely service. That's nothing to do with Sláintecare. That's just the job of this government. Waiting times were falling drastically and were 20 times lower in 2010 than they are now in certain areas. Accountability and performance is just the normal job of healthcare management. And so I'm concerned that there is a lack of acknowledgement of just how bad things have got in healthcare, both for patients and clinicians. And I'm also concerned that Sláintecare has been given the role not just of system reconfiguration, which is its role in moving to a more modern model of care, but also that it is being tasked with fixing the problems that it is just the normal job of government to fix, like waiting times and not having massive budgetary overruns every year. So can I ask you, in the spirit of trying to get this right, do you accept the failures within the healthcare system today, particularly in terms of the waiting lists, which are longer than they've ever been since records were taken? Do you agree that in order to implement a very serious and ambitious programme of change, that we're going to need much more competence in delivery from government, based on what we're seeing patients are facing every day? And can you tell us how you plan to bring that competence, given that what we are facing and what we're all signed up to is a complex and difficult and important programme of change? Thank you.
Thank you, Deputy Donnelly. So, Deputy Donnelly, it's taken 4 minutes there, Minister, so I don't know if you can answer him in 3, but
I'll do my very best. Firstly, thank you, Deputy Donnelly. Well, certainly when I look to reform, I'm definitely going to look to the future, because I'm not going to look to the past, because the way people have endeavoured to reform the health service in this country has created many of the current problems. So the idea of setting up a national entity, which, by the way, I think most political parties agreed with, was botched. And as a result of it being botched, we have layers of bureaucracy that make it impossible often for our citizens to find answers. So I welcome the fact that we have a cross-party approach in terms of how we should reform the health service that is very much better than the reforms that have gone before it. You listed a number of things that you say, and I get the point you're making, and I'll answer it, but you said they're nothing to do with Sláintecare. They're very much in it, obviously, which you very much know. So, I mean, Sláintecare talks very extensively about the things that I said in relation to waiting lists and calls on me to do them. And I suppose what I'm doing is accounting to this committee today for my intention to do them. I don't accept that everything in healthcare has gotten worse, because it depends on what you measure. So, for starters, let's talk about waiting lists. There are figures now published in relation to waiting lists that were never published before this government was in office. Outpatient figures were never published before 2014. They were never published. So people talk about figures now, you're not comparing like with like. There are challenges in relation to waiting lists, absolutely, but the number of inpatient day case, as something that your party and mine agreed in confidence and supply, the number of inpatient day case people on waiting lists is actually falling. 13,000 fewer patients on those lists. Outpatients is a major challenge. I think one of the main ways we address it, though, is through the Sláintecare model, whereby we actually try to see who can be seen locally in the primary care centre, through the GP, through an advanced nurse practitioner. But many of the metrics have gotten an awful lot better. And I think I'm not suggesting you do this, but to blame the government for all the failures and credit everyone other than government policy and investment and anything that's good in the health service doesn't stand up to much scrutiny. So if you look at kids with cystic fibrosis in this country, thank God, will now live an awful lot longer than they would have. That's as a result of great clinicians, but significant investment we've made in drugs like Orkambi. If you look at outcomes for cancer, if you look at outcomes for stroke, if you look at outcomes for heart conditions, if you look at life expectancy, if you look at trolley numbers, any person on a trolley is too high, but the trolley GAR for the HSE fell by 5% in September. So there's a huge body of work to do, and there are very, very many challenges, and I accept there are very, very many challenges in healthcare. Absolutely, I accept that. But I don't accept that everything in healthcare is in crisis, because every single day many people have a positive experience. When we actually surveyed our patients who went into the hospitals last year and actually said to them, how did you find your experience from the moment you walked into the ED to the moment you were discharged from the hospital and you had to have stayed at least one night in an acute adult hospital, 86% of people said it was good or very good. I need to be very worried every moment of every day about the 14% who didn't have that good experience. And if we're to address that, we need to implement Sláintecare. I do think this plan has credibility. I think the real reason it has credibility is because it has something that we've never had before in healthcare. It has all of us supporting it, but more importantly than just all of us supporting it, and political support is definitely important for this, it has a decent chance of being given the length of time it's going to need to actually function. Because when I became Minister for Health, and if you're ever Minister for Health in the future, what people in the health service despair about is another new minister with a bright, shiny plan. We now have one plan that we're all pulling in the direction on. It is going to require resourcing. In terms of answering your question, I suppose, about the delivery of it and accountability for the delivery of it, I am the Minister for Health. I'm accountable for delivering this. Laura McGahey is charged over the office. I'm accountable to the Oireachtas for the delivery of this plan. And if we publish an action plan at the end of this year and say we're going to do this, that and the other, and report against that every 6 months, I'm accountable to you and to the people of Ireland for
Thanks, Minister. On that then, and I'll finish on this, Chair, thank you. The short version is this. My concern is that Sláintecare is going to be tasked with solving things like waiting lists. We don't need Sláintecare to bring down waiting lists. We don't need Sláintecare to promote the health of our population. We don't need Sláintecare to drive accountability and performance. And we don't need Sláintecare to deliver a healthcare system that has the ability to plan and execute. We need Sláintecare for reconfiguration. So I just want to make that point, that bringing these waiting lists down and helping these men, women and children has nothing to do with Sláintecare. Most of these things have got worse over the last number of years. My final question then is on cash. Can you tell the committee over the next, say, 1 to 5 years, how much money you're seeking for Sláintecare, explicitly for Sláintecare activities, as opposed to the normal increases in healthcare expenditure we would expect to see? Thank you.
And in 1 minute, Minister.
In 1 minute. So we're not going to have time to have the debate back and forth. I don't agree that Sláintecare isn't the key to addressing a lot of these challenges, including waiting lists, because I think delivering what Sláintecare calls on me to deliver is key. But I take the point you're making. I can't give you an answer a week out from the budget in terms of how much money I'm seeking in the budget, or perhaps your own party indeed are seeking in the budget in relation to the delivery of Sláintecare. I'll give you one example that I can give you in terms of multi-annual. In the almost €11 billion that we have for capital, 6.6 billion of that is what I would describe as Sláintecare funding in terms of the delivery of the capital elements of it. In terms of the delivery of the current elements of it, that will be a matter for obviously budget day next week, and then the HSE service plan. I'm happy to come back and interact on it.
Thanks, Chair.
Thank you very much, Minister. And now Deputy Louise O'Reilly.
Thank you, Chair. And good morning, Minister. Good morning, Ms McGahey. You're very welcome, and I do wish you the very best of luck with the task ahead. There's an awful lot riding on it as it goes. And I was listening to the exchange there. I could play the game of which one of the previous governments had made the biggest mistakes in the health service. We could play that all day, but it probably won't advance as much. But when we are looking at you know, what has been measured and what can. The INMO have been measuring trolley weights for a long time, and they don't always concur with the HSE trolley gar figures, and indeed I think they do show a picture that is getting worse. With regard to the overspend and the carryover of recurring expenses, can you confirm that that's going to be addressed in the budget? Because talking about investment, I mean, months after the last budget, you got a letter from the head of the HSE to say that the HSE was in trouble, and that was a result of underfunding. Pierce Doherty did point it out to you, but you didn't listen. Maybe you listened this year, and hopefully you did. But you might confirm that.
Sure.
With regard to the transition of services to primary care, much of our primary care is centred around GPs. There is no evidence that I have seen that there is any progress being made on the renegotiation of the GP contract. Can you give us an up-to-date as to where that is at? I have asked repeated questions with regard to the staffing for our primary care centres. I get the same answer every single time. It's a real cut and paste job. Services will be provided from within existing resources. I can even quote it. So there's no new staff. So if you have a vision for how this is going to work without staff, I'd love to hear it. I doubt if you do, so then we need to hear about where the staff are going to come from and specifically what you're going to do with regard to GPs. The Sláintecare provides for that there will be legislation for entitlement for all residents to access health and social care, and a guarantee on waiting lists underpinned by legislation. The implementation plan has changed that slightly, and it uses the words expand eligibility on a phased basis and move towards universal healthcare. See, if it's universal, then we don't have to discuss eligibility, and there does seem to be some contradiction, and there also has been I think some slippage with regard to the universality, but also the legislation to underpin guaranteed waiting times. And I would echo the previous comments. It is very much bound up with the waiting list, because it's a mechanism by which, but the waiting lists have got to be addressed separate to this as well. The costings that the Department of Health will be using with regard to the implementation strategy, are they going to be published along with the implementation report? Because I think it's important that that we would see that, and we would see real progress. I don't think anyone wants this just to be a tick box exercise. Thank you, Chair.
Thank you very much, Deputy O'Reilly. Minister?
Okay, thank you very much. And I might ask Laura to come in just on one piece about the kind of workforce planning piece in a moment, just to go through your issues. In relation to the overspend, as my colleague, the Minister for Finance and Public Expenditure, said, I think at a Budget Oversight Committee last week, we are actively engaging himself and myself in terms of addressing what will be a requirement for supplementary funding for the health service this year, and I'm very confident that we can reach agreement on that, and that issue will obviously crystallise, and I expect it to be resolved in the next few days. In relation to the issue, it's a broader. In relation to the issue of underspend versus value for money, I think I'd need to come back and have a separate session, because I'd nearly used the 7 minutes on that. But I mean, there is a need for obviously accountability in terms of resources that are given, and there's also a need to obviously make sure we have an adequate budget each and every year within the resources available. In relation to GPs, as I said in my opening statement, I have in recent days reached an agreement with the Minister for Public Expenditure and Reform that gives me a mandate to engage with GPs on a multi-annual investment programme, a very substantial programme. Obviously, both it's the subject to negotiations, and obviously there's a budget, so I can't be more specific than that, but I do genuinely expect very intensive engagement in the coming weeks with GPs, and I expect to be in a position to be able to significantly increase the investment in general practice starting next year, subject to agreement. In relation to staffing for primary care centres, in fairness to the deputy, the deputy raises this with me on a very regular basis, so if we can try and get the deputy some specific information in relation to this. When I open primary care centres, I'm regularly told about the additional staff working here and the additional specialties being done and here, there and everywhere. So let me try and get you a note, and I'm happy to come back and debate that with you, but we will. Yeah, well, and you might even just inform the officials in your department, because I could literally paper the walls of this room
with the responses I've got, and they all say the same thing. They all say, so there may be new staff moving in from other areas, say in Balbriggan, they closed down the health centre and they moved them into the new health centre, but that's no additional staff for a town with the fastest growing population in the state. You're just shifting staff around. There's no new services can be developed just because you put someone, you take them out of a building that's derelict and put them into a building that's shiny.
No, I take that point, but just to I mean, point out, there were extra occupational therapy posts this year, there were extra speech and language therapy posts in recent times, there have obviously been the 140-something assistant psychology posts, but I take the point, and perhaps I could ask Laura to do some work in relation to that. Laura might just outline, and I'll come back on the other points, just the position of how we're going to plan for the workforce for the delivery of Sláintecare.
Thanks, Minister. Thank you, Deputy. I think you raised a very interesting question, which is about what's the new model of care going to look like when we move care that shouldn't be in hospitals more into the community. And I suppose it's around the needs of the population, and that's what the geo-alignment will facilitate. And I think the point is that it's going to need a combination approach based on whatever the needs are. So we're going to be looking at talking to the different training bodies about training extra GPs and practice nurses, for example, training ANPs and community nurses, cross-training for disciplines, for multidisciplinary team approaches, and trying to get that in at the colleges at an early stage rather than everybody being trained in their own piece and then expected to work in a multidisciplinary way later by miracle. I think also clinical managerial training, and then also the issue of starting to engage younger professionals and enlisting their views because of the disaffection that many of them have expressed in working in the system, so trying to hear what they've got to say. But it will have to follow the model of care. What is that going to look like when we start moving pieces of work that are happening in hospitals into the community?
Okay. I asked a very specific question about where the legislation has disappeared from it's in the Sláintecare report, but it's not in the implementation plan, legislation to underpin waiting and the worrying move from universal access to expanding eligibility, if you could. Yeah, thank you.
No, sorry.
So I'm just conscious of time as well.
Fine.
I don't want to be into other people's time.
It's something myself and Laura have discussed in recent days. I actually agree with you on the word entitlement versus eligibility, and we're going to revert to using the word entitlement. The idea is that every citizen in this country should be entitled to access care in their community. So that's the first piece. We want universal entitlement, universal access to primary care. Second piece, though, and it's an important piece, and it's outlined in actions in section 6.2 of the 106 actions we published. Sláintecare does say it should be low cost or no cost. That's a direct phrase in Sláintecare. Might be no cost or low cost, but Sláintecare specifically refers to that. So you will see in action 6.2, 1, 2 and 3 very specific actions we're going to undertake in terms of establishing the framework, developing the roadmap for achieving universal access, both of which will start next year. So that is still the position. On guaranteed waiting times, we are committed to doing that. The implementation plan is committed to doing that, but we need
Sorry, could you just point to me where it is, because I didn't see it now. That's obviously
no, I know you're not. No, I hope I'm right, but we will be legislating. Okay. Sorry, 1 second. No, that's not it. Sorry, just while I'm looking for that, I mean, what we will be. No, that's not. It's not 623. No, we will be. I'll come back on the specific number in one moment, Deputy. But I do want to legislate for wait times. And I've talked to the Scottish Health Minister about this last Friday as well. I want to do it, and I want to be able to ensure we can actually deliver them. And I think the elective-only models is how they did it in Scotland. I want to see if we can. We've given a commitment to picking 3 sites next year for the delivery of elective-only hospitals. I want to see if we can move ahead quicker with 1, so that we can actually have a demonstrator project. And then we will then legislate for the wait times. But I need to make sure I have the capacity before legislating for the wait times. And I'll come back to you just momentarily on terms of further insight. And did you ask me another question? Sorry, did I answer your question?
Publish the costings along with the review and the updates. And
so each year we'll obviously have to say what we're going to do in 2019, and 2019 being the next one, and we'll obviously have to show how much it's going to cost and how we're going to deliver it. So yes, in terms of the
costings will be published. Excellent. Thank you, Chair.
Are you happy with that?
Where that is in one moment.
Ecstatic, Chair. I'm a happy person.
Thank you. Now, Deputy Alan Kelly, your 7-minute slot.
I'll be very disciplined, Chair. Thank you very much, Minister. Thank you very much, Laura. I don't know whether to say congratulations or sorry for your troubles, but
It's all our troubles, Deputy.
Can I just, before Deputy O'Reilly leaves, it's action 5.16, but I'll send it. I'm sorry, Deputy.
You're okay, Minister. So best of luck.
Thank
A number of questions. I'll start off. I don't have too many, but they're quite specific. First one is in relation to your own role, Laura, and this directly to yourself. I was one of the, I don't know how many of us are in the room who wrote the Sláintecare report. The specific, in fairness to them, the specific structures that have been put in place are what we asked to be put in place as regards advisory council, as regards where it fits within government, as regards structures and everything like that. So two opening questions on that is, one, what are you going to have as your own resources? I know you said small team earlier on. What are they? And secondly is, within those structures, there's no doubt that you're going to have frustrations. Dare I say, some of them with the man sitting beside you from time to time, just or whoever's sitting beside you. How are you going to deal with them? How are you going to ensure that you can get traction within the structures that have been put in place when you're missing deadlines, timelines aren't being put in place, resources aren't available? Because, you know, there will be absolutely an element of that. So how are you going to use those structures, or what are you going to do to ensure that you're getting what you want and when you want it? That's the first thing. Second question, that goes to you, Laura. Second question relates to the 106 actions. And obviously then there is a whole area of the first number of years there's prioritisation. For instance, one of the biggest prioritisations which I insisted on was in the whole area of community care and bringing that forward. All the issues in relation to home help and a whole range of stuff there, which is common sense as far as I know. The whole issue of bringing forward diagnostics, because it's creating blockages all over the place. So could you use that as an example in your answer as to how you see now, I know you're only there 25 days, but the pathway towards how that's going to be achieved and how you're going to interact within the structures to make that be achievable within the 3-year time frame? Second question. Third question, Minister, hospital capacity review and the implementation. And thank you for your, thank you for your news. You more or less said that the 60-bed unit in Limerick is going to be part of the plan that's going to be announced. So thanks for confirming that. I appreciate it, because Clonmel, I get the benefit of having the two worst situations as regards A&Es and people on trolleys in either side of me, in Clonmel and in Limerick, in the whole country. So thanks for confirming that. But as regards the actual capacity, I presume there's going to be some process whereby the alignment of this work with the alignment of Sláintecare is going to be engineered, because it's critical that it is. So that's a definite one for yourself. Second one, Minister, you might just outline a little bit more for us, and best of luck with this one, and I mean that in jest, but the whole issue of G-alignment, you said you had timelines for that. What are they? Yeah. Because again, I actually agree with you that it has to be brought forward, because I don't think Laura's work can actually progress until that alignment happens. And the final question our final two questions is, when will the report from the committee of Donnelly Butler be available in relation to public-private? And last one is, you've made a statement there in relation to the GP and GP contracts, I presume in relation to multiple annual funding. You know, many of us here and there say, Senator Swanick will probably have questions on this later on, but we all know that the level of progress isn't what it's at. So are you saying that you've got this agreement now that you're going to see progress, you know, moving at a different pace imminently? So they're my 6 questions. I think I've been succinct, Chair, hopefully.
Excellent, Deputy Kelly. Thank you.
That's the first.
Equally. Ms McGahey.
Thank you, Deputy. I suppose in terms of resources, I have outlined 4 work streams, how I'm going to structure my 106 actions. This is just work in progress. And they are around the citizen care master plan, so I will need population health planning expertise as part of my team, but also working out in the system with people who have that expertise. In terms of coordinated governance and value for money, which is my second work stream, I will need finance and governance advice into my team. My third work stream is about teams of the future, and I've talked a little bit about that. Obviously, I'll need workforce planning expertise. And finally, I have a sharing progress work stream, which is about comms and engagement. But through those, we'll have some service design people, some project managers, critically, and then I'll need input from different people at different points in time. So we've got economic background or whichever piece they're needed at the time. So between now and the end of the year, I'm working out how the action plan is going to be structured, what my team is going to be in-house, but I'm going to keep it tight because there is expertise out in the system, and I'm proposing that the office is a kind of a bridge out to the system, and that we just to make sure everything is coordinated and happening in the right sequence. So I hope that answers your question.
Yeah, and just the second part of the question, what happens when you don't get what you want? What are you going to do?
Well, I can't anticipate that because I'm sure I will get what I want.
Well,
but if I don't, being serious, you can't do something unless you know you have the right resources in behind it. So I won't be promising that I can deliver something unless I have the right resources. And I won't know I have the right resources for the next number of months. And to be fair, until I've worked out what the priorities are, which will be at the end of the year, which I've committed to doing, which I will do, it's hard to predict exactly what they will require. But I think the things that you outlined there in terms of bringing the community care closer and making sure that that works properly is definitely, and the things that you outlined at the home help, etc., the diagnostics, they're absolutely priorities. If the whole system is going to work, that has to be a first focus. Thank you.
Thank you, Laura. Thanks, Deputy Kelly. So, yeah, University Hospital Limerick has one of the most acute situations in terms of a lack of bed capacity. You've highlighted this here many times before. They're working very hard at a hospital level to develop not just to develop a modular proposal, but to deliver on it. My understanding is that they sought planning permission, and my understanding is that there may be a further appeal there, but I'm not subject to that information. I've just read that somewhere. But subject to that being rectified, I want to see this progress, and I want to see it progress urgently. I think
timelines?
It depends on the completion of the planning process. But
just say that's done in a few months.
But we'll be ready to go as soon as they're ready to go.
Okay.
In terms of progressing it. And I want to thank the hospital group CEO, but she put a lot of work into it and didn't ploughed on with it as well, which I think was very important in terms of being ready. And obviously in Clonmel, as you know, the 40-bed modular is also progressing, and my understanding is it's due to open very early in the new year, but I'll confirm that with you. But it's progressing well, is my understanding, and I hope to be in a position to visit it shortly. On the geo-alignment, what you've said is 100% correct. I mean, if the idea of Sláintecare is to reduce bureaucracy, increase accountability, and move more services locally where appropriate to do so, we need to have regional entities with joined-up thinking and a continuum of care for the patient. So until we kind of address that, grasp that nettle, we can't move forward much further. So that's why we've taken a decision, and there's a number of actions. The first strategic action, we've said that we will consult and finalise decisions on the geographic alignment of hospital groups and community health organisations by the end of this year. So I will announce by the end of this year what I expect, or what I would like, it'll be a matter ultimately for the Oireachtas to legislate, but what I would like to be the regional entities. We will then in 2019, this is another specific action, we'll introduce modifications to the hospital groups and community health organisations to ensure geographic alignment, and we'll begin to develop processes for integrated performance management on an interim administrative basis, so let them bed in and test. We'll start in 2019 to devolve decision making. We've done this already with the hospital group, so we'll devolve decision making and autonomy in line with their functionality. And then the action plan says in 2021 we'll legislate for these revised structures. But if I'm to be very honest, if there was a willingness in the Oireachtas to legislate a little bit earlier than that, I'd be very open to doing that as well. I'd like to do that quickly. The other action, just on the alignment piece, Chair, and it's an action for next year, and it's a really important one, is as well as doing this, it's also to define the new organisational operational structure in terms of what will the new slimmed down HSE do over time, and what will the Department of Health do over time. So a Department of Health in the context of Sláintecare, a HSE in the context of new regional entities and the regional entities. So there's 5 specific actions there on geo-alignment, all taking place kind of by the end of this year or next year. Dr. Donald de Butler's group, his original timeline is he's due to have his work, publicly he's stated he'll have his work completed by the end of this year. So I'd hope to receive that report by the end of this year or very early at the start of next year. It's going to be a very important piece of work. As you know, there's many vested interests arguing as to why we shouldn't do this. There's many people that you and I represent that I think need us to get this right, but we do need to get it right on a phased basis and in an appropriate way. And I'll be very much influenced by the work of that expert group, which contains a lot of really good expertise. On the GP contract, put bluntly, yes. I expect now to be in a position to see progress if there's a willingness on both sides, which I think there is. In fairness, I really think there is. But it takes two sides to negotiate. I have a mandate now from Public Expenditure Reform and my own department in terms of both policy objectives being aligned with the funding stream.
Good. Thank you.
Thank you very much, Minister. Now we are going to invite Deputy O'Mahony. Thank you.
Thank you, Chair. First of all, I would like to thank you both for coming in here this morning, and to especially welcome you, Laura, and congratulate you, and to wish you well. It's not going to be an easy task, and if there's anything I can do personally,
thank you.
My door will always be open to you. I'd like to say well done, I suppose, at the start to everybody who is involved in Sláintecare. I know an awful lot of hard work went into it, and I think it is fantastic that health is now above politics, and that it will, through this plan, remain that way, and that we will be all on the same hymn sheet. And I think maybe other departments should take notice of this and act accordingly. Just a few questions, Minister, and apologies if other people have asked them. I had to step out to meet some farmers that were up from West Cork. It's very important. So, Minister, you were saying there it'll move our system to a population-based approach. You might just go into that a bit further, please. You said new models of care will be designed that are structured, coherent and tailored to population need. When do you envisage this happening, and could that not have been done already, or started already anyway? You were then saying Sláintecare implementation will require a stronger system of community care. Is this system decided on already? And then you were saying Sláintecare, and I know this is kind of your motto, I suppose, that it will be for those who need it most. I suppose I just find that term very abstract, and I was wondering what will be your criteria, or who will decide who actually needs it most. I think that's it, Minister. And Minister, just, I know this may not be the forum, but just on a personal level, can I ask your permission to contact you about a matter? I had a constituent on to me this morning who has been waiting 17 weeks for a smear test result. It came back unclear, so was advised to retest, but has been told she will now have to wait another 17 weeks for the second result. So if it's okay to contact you
it's happening
after.
around the country, Minister, just to broaden it out. That's it's becoming a real issue.
Yeah. Well, I'd be happy to talk to you, Deputy, in relation to that, and Deputy Kelly also. Thanks. Oh, sorry,
Thank you.
Thank you, Chairman. Sorry. Population-based approach. I suppose we've got to make sure that we design the structures based on where our population are, rather than actually designing the structures and then hoping the population effectively find them or make their way there. And if we can look at a map of Ireland, not just in a geographic sense, but a map of Ireland in terms of where our citizens live, the needs of our citizens, what Laura has talked very passionately about in terms of citizen engagement and empowerment. What do the citizens of your region or my region want their health service to look like, and that we put the structures around them, rather than doing what we've often done in healthcare, put the structures around and then tell the people to go and the patients to come and access them. New structures, very valid question, a question probably a lot of people at home are asking too. Why hasn't this just been done so far? I think, and you made the point about it being above party politics, which is exactly the answer. I think the risk is if I, as the current minister, or anybody before me or after me, tinkers with the structures and starts changing the structures, the issue is they're then this minister's structures or the next minister's structures, and they don't often last the test of time. And we've seen far too much chopping and changing. By all of us collectively as a political system, we're guilty of this. Far too much chopping and changing, never allowing the health service actually to properly bed into a programme of reform. The beauty of this programme and the difference is that I'm the current incumbent. We go ahead and we'll implement this, but in all likelihood, anybody who will come after me has signed up to this as well. And I think that's what gives it a really, really good chance of standing the test of time and actually being able to get done. In relation to community care, so on some of the issues we've made progress. So, for example, we've given a commitment to a statutory home care scheme, which is, I know, something you believe in very strongly, the idea that we say as politicians we want everyone to be able to grow old at home in their own home, in their own community with dignity, but the only statutory scheme we currently have is the Fair Deal for nursing home care, and home care around the country is variable in terms of its delivery. So the idea that you'd have a statutory home care scheme is one example of the community care. Obviously the model that we need to roll out in terms of our nurse practitioners and the GP contract is that piece of work is still ongoing. What do we mean by need it most? So what we mean is trying to move away, and I think in fairness to the authors of Sláintecare, many of you whom are here today, and it's a view I share, it's to try and move away from the fact that if the ability to pay trumps the medical need. That we actually ultimately get to a system whereby nobody lies awake at night in bed wondering, do I have the money to go tomorrow to access healthcare?
Okay. Thank you, Minister.
Thank you very much. You're happy with those answers? Yeah.
Thank you.
Now, we're going to ask Bernard Durkan for his 7 minutes. Deputy Durkan.
I'm going to give the whole 7 minutes in one go, Chairman, and I'm going to come back to a second one.
bread.
First of all, I would like to welcome the Minister and Ms McGahey and officials, and to wish you very well in the task that you're undertaking. You need all the luck in the world, and you need all the assistance in the world. The structures that are now emerging are not exactly my first choice, as you know, Mr. Chairman, because the question that comes up all the time is whether or not the HSE is the appropriate structure to deliver throughout the country evenly the services that are required. I still hold that view, but I do note that the implementation group does have a minor version of what I had in mind. Hopefully it will work. I think that the questions I want to ask are simply this. The population of the country has increased considerably in the last 10 or 12 years and will increase more. It's double what it was in the early 60s, so that has to be taken into account. We need to, if we're relying on community care and primary care systems, then we need to know whether or not we have the capacity and the capability to do the job that's required at that level. And we haven't found that out yet. It hasn't been identified yet that we have that. We don't know whether we are utilising the facilities that are available. For instance, the theatres, the various consultants and so on and so forth. This is not going to happen unless we have round-the-clock delivery of services. People don't get ill just Monday to Friday. It continues on, and it's serious, and it accumulates. And unless we do something about that in that particular area, then we're going to have a continual problem. The bed shortage issue, I'm glad to see, is being addressed. But we've had people come before various committees that I've been a member of, health and otherwise, over the past number of years, who kept repeating to us that we had too many beds. And still repeated from time to time. And I'm glad to see that at last there's recognition we give to the fact that we need to have accommodation. We need to have the bed accommodation, and we need to ensure that we don't have patients being parked around corridors in order to create a health and safety issue for the parents, for the patients, for the staff, and for everybody else and the system. We need also to compare our costings and our expenditure with other OECD countries. So there's no use in spending higher than everybody else, on average, and delivering less. We have to deliver on par with our competitors. If we can't do that, then we have a problem. There are specific areas where treatment has been lacking in recent times. Scoliosis has been one case in point. And I can't understand, Mr. Chairman, how, for instance, a survey carried out by RTE, it took that to identify the extent and the most acute part of that problem in the very beginning. That shouldn't happen. If the system is internally capable of doing the job, and it is vigilant and doing the job it's supposed to do, then we should have seen that beforehand, long before we got to that stage. And the point I would emphasise there is that those who are children on waiting list or other patients on waiting list with an acute problem, you know, we need to be able to deliver the services to them in a much sharper fashion. And there are countries who do that with less facilities than we have. The other one I want to just break briefly, and you tell me, Chairman, when it's time for me to pull the handbrake. We're not doing so bad. The other point...
We do need to get the answers from the Minister.
No, we'll get the answers all right, don't worry. The other point is that primary care centres... I've raised this issue before, Chairman. I'm not certain that the primary care centres are capable of delivering the quality and level and extent of community care replacement that is now required. I don't know. I have yet to see it. But I do know this, that in some of the primary care centres, as they are constructed now, there is not equal participation from the public sector, nor equal access. And that's not much good to us if we're trying to deliver a service to the general public. The last point is in relation to... I think that's enough, Mr. Chairman, for the moment.
Thank you, Deputy Durkan.
I just handbrake a bit earlier.
Minister and Laura McGahey.
Well, thank you very much, and thank you, Deputy Durkan, for affording me the time to reply within the 7 minutes. I don't disagree with you at all, actually, that the current construct of the HSE is not fit for purpose. And in fact, that's just not my view. It's actually the view of the HSE. If you remember, the former Director General of the HSE here at this committee said that before. I think he himself called it an amorphous blob, I think was his description of it in the national media. So the HSE as constructed is not fit for purpose. I do believe, Sláintecare also believes, that there is a need for a national entity. I believe there's many good things in our health service that would not be achieved without a national entity. One being the National Maternity Strategy, one being the National Cancer Strategy, potentially procurement, HR. You know, there's things that it makes sense for the national core to hold on to. But the national core is far too big and far too bloated. The idea is to devolve as much as possible to the regional entities and have those regional entities have a board and be accountable. I find all too often in this Oireachtas, and this is not a criticism of anybody, I find myself in this position, people in this Oireachtas raise questions that really, they raise them here because they can't get answers at a more local or regional level. So to be able to afford the local population access information about their own healthcare in a local or regional setting makes sense. You're entirely correct to raise the idea of population increases, because everyone talks about the health service as though it's static. Thankfully, we have a growing population, and thankfully, we have an ageing population. People are living much longer in Ireland. We want them to be able to live good, healthy lives and quality of life, healthy years as well. Let me just be very clear. The mantra of there's too many beds in the Irish Health Service, that's gone, it's over, it's dead. We have far too few acute hospital beds. It is highly regrettable that we went through an era of people deciding with too many beds. And it wasn't an economic argument, it was an ideological argument. They actually believed you could do all of this in primary care. Yes, you can do a lot more in primary care, but we have the evidence in the bed capacity review that you still need a lot more acute hospital beds. The person who needs an ICU bed is never going to be seen in primary care. We don't have enough of them. So you do need increased acute capacity with the primary care piece. On the primary care centres, look, you're right to ask the question. I believe they do have the capacity to do a lot more. I'll give you the example of the one I visited and opened in Castlebar, where they now have an X-ray facility in that region. Under the governance of the hospital, under the governance of Mayo General, but you did, and Senator Swanick will know this well, you did have a situation where lots of people were having to go to the General Hospital. There was a waiting list for X-rays. The operation of that X-ray facility has effectively eliminated the waiting list for X-rays. So we have all these fine buildings now. There's a lot of good work going on in them, and I don't mean in any way to downplay that, but there's an ability to do a lot more. Myself and Deputy Donnelly in the constituency we represent in Carnew, there's a primary care centre. Before that was in place, people from Carnew and South Wicklow were travelling to the Mater Hospital for wound management. That can now be done locally. So there's definitely ability to do an awful lot more in primary care, and that's what Sláintecare is about, but it's also what our capital plan is about, putting the diagnostic infrastructure in place.
Very good. Thank you very much for that. Now we have Senator Swanick from the Upper House.
Thank you, Chair, and thank the Minister for coming along, and congratulate Ms McGahey on her new role. Briefly, I'd like to speak primarily initially just about primary care, and I welcome the Minister's comments with regard to funding on primary care, with regards to multiple annual funding. Does the Minister see any possible rollback with regards to Friendly cuts with regards to general practice? Because often, whilst I totally agree with what Deputy Durkan says, I welcomed the primary care infrastructure plan and producing more primary care centres around the country. but it's not necessarily, and I've said this multiple occasions, about the bricks and mortar. It's about the activity which happens within the primary care setting. And with a small amount of funding, huge progress could be made on a day-to-day basis, providing higher quality care to patients, and that's basically what it's all about. As we all know, general practitioners on a day-to-day basis are often doing nursing duties. And I think, personally think, and I think a lot of my GP colleagues around the country would agree with me, with this, a small, even 10% reduction or refund in the FEMPI cuts, for example, we could facilitate sending our staff on training, for example, nurse prescribing. And I think that too much emphasis has been placed on the provision of primary care centres around the country, when in fact it's the provision of care that's important. And would the Minister agree with me that any possible reduction in FEMPI cuts in the general practice sector should be kept separate than contract negotiations, or will that happen in a sort of in an aligned fashion? Also, I'd like to just talk briefly about, we talk about marrying primary care and community care, and we talk about providing new beds, more beds in the hospital sector, which I agree with. And the Minister mentioned there that the HSE has said that there is a capacity to provide 600 new beds between modular units and reconfiguration of existing wards, etc. But I believe that there is a hugely underutilised resource, and I've spoken about this on numerous occasions, and that's the community hospital sector across the country. And is there a specific fund within the implementation strategy with regards specifically for the community hospital sector? Because you mentioned there the X-ray department, for example, that has been installed in the new primary care centre in Castlebar. But we have 4 district hospitals and community hospitals in the Mayo region. And there's an X-ray department in Belmullet Hospital that's used once to twice a week, and there's an X-ray department in Ballina Hospital. So the community hospitals should not be seen as a relic of a bygone era. There are a huge resource of beds that are not being used currently. They should not be seen as glorified nursing homes. They, in fact, help facilitate discharges from hospital, and they prevent admissions to acute hospitals. And there is no reason why somebody who has a hip replacement carried out in a Mayo General cannot be rehabilitating in Balmullet 2 days later, or in Castlebar or Swinford, or wherever it is. So I think we need to specifically look at the redevelopment of our community hospital sector as a method of taking the pressure off the acute sector, and opening access to GPs to admit to the community hospital sectors directly. Because, for example, people can be admitted there, they can have a medication review, they can have a chest x-ray, can have some blood work done, for maybe an elderly person, maybe a brief admission for 1 week, and that will prevent an admission to the acute hospital sector, save lots of money. So I think this is something that needs to be looked at, and may have been overlooked with regards to the whole Sláintecare report, and I'd like your thoughts on that matter. Thank you.
Thank you, Minister.
Thank you very much, Senator Swanick. I firstly agree with you. I mean that bricks and mortar cannot be and is not all that there is to primary care. The buildings can indeed be enablers for change. They can be enablers for integrated care, for multidisciplinary working. When I opened one in Grange Gorman only a few weeks ago, it had brought together, as you know in your own profession, it had brought together lots of healthcare professionals who all of a sudden, for the first time in many of their professional lives, were working together under one roof, providing integrated care for a patient. So that's the benefit I see in the bricks and mortar, but it's not the end of the conversation, because it's what happens within those bricks and mortar that is really, really important. I don't want to negotiate with GPs through this committee. They never like that. But I would make the point that, in my view, there's 3 elements to any discussion that we need to have. There's an element about sustainability. You use the word FEMPI, I'm talking about sustainability, but we're both talking, I think, about recognising the fact that GPs today, in many cases, feel they're in need of supports to keep their current practice and their current services sustainable. So I think we need to talk about that. before, and that I hope you notice I'm separating and making that a distinct point from new services. So I think we need to talk about sustainability of our existing general practice service. I think the second thing we need to talk about crucially, and I referenced it in my opening statement, and it's all throughout the Sláintecare document, both the committees and my implementation plan, is chronic disease management. So sustainability being one leg of a discussion, chronic disease management, what can general practice do on chronic disease management if they are resourced to do it? And I know from my own conversations with GPs, there's a willingness and a desire to do more there, but they need to be resourced to do that. And then the third leg of that stool, if you like, is a conversation around access to primary care, and how do you advance the Sláintecare ambition in relation to access. So I think it's three things. It's sustainability, chronic disease, Sláintecare chronic disease management, and Sláintecare access. And I think they're the three legs of a stool that we need as a state to have a very serious conversation with general practice about. I need, or the state needs, to be able to come to that conversation with significant resources. I believe I'm now in a position to do that. And we need GPs to come to that table as well with a willingness to engage. And I believe that's there too. So I would hope that re-engagement could commence quite quickly. On the smaller hospitals, I fully agree with you. I think we're underutilising our smaller hospital network. That's not... it's important that we provide the right care in the right place, and you know this as a doctor better than I do. But there is capacity within them to do more. In some areas it's in the diagnostic space, in some areas it's in the elective space. Take the Nina Cataract Theatre we open now, serving the people of the Midwest to reduce their cataract waiting lists in what would be called a small hospital. I visited Kilcreen Hospital in Kilkenny recently. They said, Minister, we have the staff here actually to do more hip operations. Will you fund us to do more? And I'm pleased we were able to do that. So there are smaller hospitals, often staffed smaller hospitals, with capacity and a hunger and an eagerness to do more. And definitely part of Sláintecare's work is to look at all of the assets, if you like, within the public health service, all of the capacity and how best to utilise that. And I think you make a fine point in relation to smaller hospitals in that regard.
But even the district hospital network, they're very remote hospitals. For example, pulmonary rehab, cardiac rehab, where patients don't necessarily have to travel the 1 hour, the 1.5 hour to go to the main acute hospital. These can be all remote services to facilitate the preservation of our district hospital network. So with a little bit of lateral solution-driven thinking, it's very simple to put good services that really benefit patients in place at very little cost.
I agree with that. And I think a lot of these facilities, a lot of the cost is in the capital space, not all, but a lot. And I'm pleased that our capital budget has increased significantly, which will enable us now to have those conversations.
Thank you, Senator Swanick. Just to return to an issue, Minister, and my sense is that there is not sufficient urgency in pursuing the reform programme, because when this government came into being, you said, I can't talk about reform until after Sláintecare delivers its report. Now, we did take 6 months longer than we had anticipated, so we have to take responsibility for that 6 months. But in relation to that then, Minister, it's now 17 months since the report was published, and we're still talking about devising a plan. So I'm just concerned that there is a lack of urgency, because effectively, in relation to what Senator or Deputy Donnelly said, in relation to waiting lists and trolley queues, we're really locked and loaded into that system for the next 3 years. You did say the trolley numbers reduced in September, but the reality is the trend is upwards all the time. Year on year, the trolley queue is increasing, and that is a symptom of what is happening in the wider health service. The trolley queue should not be the focus, but it is a symptom of what's happening. So I'm just concerned that there is a lack of urgency, because demographics are marching on. Demographics are not staying static. So our people are getting older, they require greater health care. The older population are the ones who consume the healthcare most. So the demographics are not waiting. And in relation to Senator Swanick and in relation to the GP negotiations, I mean, effectively no GP negotiations happened this year. 2 meetings, 3 meetings, nothing. And now, as we approach the budget, there is a sudden surge of activity, which was, I must say, the same surge that was at last year's budget, and nothing happened. So I'm just concerned that the budgetary cycle is stimulating movement, and then it peters out for another year. So I'd just like you to address the urgency with which you're going to approach the Sláintecare reform programme.
Sure. Look, Chairman, I mean, your bona fides in relation to healthcare are beyond question, so I hear your frustration, and I know that it's coming from a very genuine place. There were timelines in the Sláintecare report, and I've said this before, that were quite simply unworkable. And if anybody thinks that they were, that's a misplaced view. The Sláintecare report was produced in May, and I don't want to end on a sour note in relation to it. It suggested that I'd have an executive director appointed in July. It suggested that that's not how the world works in terms of recruiting highly skilled professionals like Laura McGahey. You can't hire somebody within 2 months. It suggests that we should increase access to free GP care by $500,000 a year. Now, not speaking for either of the GPs in the room, but I've yet to meet a GP in my constituency or in my role as Health Minister nationally that believes that was sustainable and wouldn't just result in a very lengthy waiting list for general practice. So whilst I fully subscribe to the agenda of Sláintecare and the end point of Sláintecare, there was a fair amount of work to do in ensuring the correct sequencing of Sláintecare so that we don't just create waiting lists in a primary care setting. If we accept that general practice is one of the best functioning parts of the health service.
In fairness, Minister, Sláintecare did say that you could not extend eligibility without extending the capacity in primary care.
It did.
The stimulus for that was to expand the capacity in primary care so that you could extend eligibility. There was no expectation that you would give free care to 500,000 people on the present manpower and workforce.
I think that's right. But again, the timelines didn't. I mean, I'm not here to be negative. I want to get on with this. But I mean, the timelines were somewhat contradictory in relation to this because it does talk about significantly. You're right. It does say increase capacity, but it then also says, make sure you extend the eligibility in a very short period of time. That wouldn't have worked. I want you to know, though, that we are extremely eager, and I don't just mean me as the Minister for Health, but my department, the Sláintecare office, the HSC. This is the plan, the only plan in relation to health reform. We are moving now beyond just kind of conversations of what my view on Sláintecare is to a point where we have an implementation plan, but even better still, we'll have the action plan at the end of the year, what we're going to do, who's going to do it, which I think will help you in your scrutiny and accountability role at this committee, and then publishing reports measuring against that every 6 months. So there'll be nowhere to hide here in terms of people getting on with the reform agenda. What I'm particularly hungry to do, and maybe this is not the most politically intelligent thing, but I believe it's absolutely crucial, is the geo-alignment piece. I believe it's really crucial if we want to provide regional integrated care and singular budgets. And I'm going to invest political capital in actually trying to bring that forward at a quicker pace than was originally envisaged. And on the GP contract, look, you and I discuss this on a very regular basis. It has taken far too long. I do now have something that I didn't have before, which is an agreed mandate and a multi-annual funding, and we will go at this hammer and tongs to try and get it agreed.
Thank you, Minister. Now, Deputy Donnelly.
Thank you, Chair. Minister, there's 5 questions I'd like to put to you if I could. The first is on the waiting list. I want to go back to this because I've been reflecting on what you said, and actually I think it's a fundamental point. My view is that the current waiting lists have nothing to do with Sláintecare, whether it exists or not. They have grown beyond recognition. They have grown to levels we've never seen in the history of the Republic across the board. My question on this is, do you accept that solving these waiting lists is possible without Sláintecare? That is simply a role of government, whether or not the Oireachtas had ever published a Sláintecare report. Do you accept that essentially it is your role, regardless of what happens in Sláintecare, to bring these waiting lists down, because they have reached hellish levels? The second question is on funding. Sláintecare and the Trinity team, who we're hearing from later, say that Sláintecare is predicated on about a 7.5% growth a year in funding. Now, off a base of about 15 billion euro, that's about 1.1 billion euro a year just for Sláintecare. I appreciate that we're a week ahead of the budget. I'm not asking you what you're pitching to the Minister for Finance for next year, but can I get your view as to whether you are looking to meet a broad funding goal that is in line with Sláintecare and the Trinity team, which is about 1.1 billion a year for about 10 years. That's 1.1 billion each year in addition. The third question I have, Minister, is on the funding overrun for this year. Obviously, it's very serious. We're being told it might be north of 600 million euro. Is that funding overrun likely to impact on the ability to invest in Sláintecare for next year? That's the third question. The fourth question, Minister, is on assets, both in terms of people, clinicians, doctors, nurses, speech and language therapists, and everybody else, and the physical assets, beds, hospital, primary care centres, diagnostics, etc. When do you believe you'll be able to present the committee with a year-by-year forecast for workforce? We're going to need this many doctors, this many nurses, this many paediatric consultants, this many primary care centres, and in different parts of the country. When do you think you'll be in a position to present a forecast on that? And my fifth question, Minister, is around, it's something you said earlier on, which is that the HSE is not fit for purpose. The danger is that health ministers make statements like that without a very definitive plan for what is coming in its place. In the UK, Andrew Lansley did it. He was appointed by Prime Minister Cameron, and one of the first things he said he was going to do was disband NHS trusts, but with absolutely no idea what he was going to put in their place, and it caused chaos. Minister Riley, one of his greatest mistakes, in my opinion, was arriving into the ministry and saying he was going to get rid of the HSE, but with absolutely no idea what he was going to replace it with, which again caused chaos. So you're saying the HSE is not fit for purpose. I think many people would agree with that, in spite of some phenomenal people within the HSE working every day to help people. When do you expect to have a new organisation in place?
Yep.
Thank you.
Thank you very much, Deputy Donnelly. So just to take the questions. Yes, I do accept we can make progress on waiting lists in advance of Sláintecare and aside from Sláintecare. I do believe, and I'm not being pedantic on this, but I do believe the policy shift that Sláintecare represents will help improve waiting lists. And if we don't do it, if we didn't have Sláintecare, that would lessen the pace of progress. I do think that's a fair comment. But yes, I mean, we are not, and just to be very clear to anyone watching this, we are not waiting for the delivery of Sláintecare to work every day to try and improve the waiting list situation. I don't want to be pedantic because the waiting lists are too large. But this never-before-seen piece, a lot of these waiting lists were never before published. It is a point worth making. For example, we now publish, and I did it in light of the RT Primetime Investigates, we now publish pre-planned and what they call TCI waiting lists. They were never ever published in the history of the state, as far as I can see, before I became Minister for Health. Outpatient waiting lists were never before published in the history of the state before 2014. Still too high, still too many people on waiting lists. But it is something that needs to be factored in. In relation to the costs, I said this on the day I launched the implementation plan in government buildings. I mean, I think largely speaking, the costs outlined by the Trinity team and the committee are in and around right. But and back to my point with the chairman, there are a number of variables that you'll appreciate and that you know in relation to a significant amount of it is dependent on contract negotiations, and I don't just mean with GPs. I mean you'd also need a new consultants contract at some point. A significant amount of the cost will be dependent on the decision we take as a government and as an Oireachtas on public and private, because at the moment, as you know, the private health insurance significantly contributes, if you like, to our public hospitals. So if we were to decide to withdraw, that's a cost factored into some of those figures you've mentioned as well. And obviously some of the costs are capital and some of the costs are current. But largely speaking, I'm not having a row with Trinity or the Sláintecare committee about the figures, but I'm just making the point. But it's the sequencing in which you do, and it's some of the policy decisions that we've yet to make as an Oireachtas. So for example, Sláintecare didn't say remove sorry, I think it did actually say remove private practice from public hospitals, but it also said before you do that, will you do this piece of work and come back to us on a roadmap? And that's a very big chunk of money in terms of the overall impact on a yearly basis in relation to the health service. The funding overall...
Sorry to cut across, Minister. Just on that question, the question was a slightly different one. Okay. So what you've answered is that you're broadly in agreement with the Sláintecare stroke TCD figures of about 1.1 billion. The question was just slightly different, which is...
Sure.
Is that what you're there for, notwithstanding any negotiations with the Minister for Finance for this year? I appreciate where we're at in the budget cycle. But in terms of, say, a 5 to 10 year view, is that the around the level of funding that you are making the case for Sláintecare to be implemented?
Yeah, I'm making the case for the full delivery of Sláintecare over 10 years. What a government, any government, and any Oireachtas is able to deliver in 2019, 2020 is a variable situation, and it depends on choices that your party makes, choices that my party and the government makes as well. But I expect to be in a position that we will have funding allocated to Sláintecare this year that will enable them to progress. But yes, over the lifetime, I want to see Sláintecare implemented in full over the lifetime of the 10-year strategy.
Thank you.
On the funding overrun, Minister for Finance is a greater authority than me in relation to commenting on these matters, particularly at this time of the cycle. But the Minister has made it clear that he believes the funding overrun in health, which sadly is not a new phenomenon, and I think is part of a reflection of the fact that, I suppose, of the need for Sláintecare to have a more efficient, accountable, transparent model in terms of funding and delivery. He has said it won't affect his spending or taxation plans for 2019, and I take him at his word in relation to that.
And your understanding, that, Minister, is that therefore it should not affect the ability to invest in healthcare next year?
Well, when he says that it won't affect his ability in terms of his spending or tax plans, and health is in the spending space, yes, that's my understanding. On the assets, I'm going to ask Laura to talk about that, because she's a body of work to do in terms of exactly what you say, Deputy, mapping out the needs, both in terms of the people needs and the capital, the infrastructural needs over the next number of years. But I just want to come back to the not fit for purpose comment, because, so firstly, the reassuring thing, I suppose, is it's not just the Minister for Health that's saying this. The Director General of the HSE said it. So I don't think, and you're right, and I'm glad you made the point, and I'm happy to echo that point, there's many brilliant people working in the health service. So this is not a jibe by me or by any politician at the HSE in terms of the people in it or the work that they do or the work that they're endeavouring to do. It is a recognition that the way it's currently set up is not fit for purpose. So just to be very clear, under Sláintecare, I still envisage a HSE existing. So the HSE will continue. What it will be, though, is slimmed down in terms of many of its functions being devolved to the regional entities in line with Sláintecare. So unlike the UK Minister you referenced, I mean, I'm very much making my comments in the context of the plan that we're now initiating. And when do I expect to make those changes? Well, I expect by the end of the year to be able to come back to this committee, if you wish, or the Dáil or wherever, and say this is what I think, based on the Sláintecare report, the geo-alignment should look like. In 2019, we'd begin to administer to devolve some of those functions on an administrative basis. At the moment, the implementation plan says we'd legislate then for those changes in 2021 to allow the system bed down. But as I said to Deputy Kelly earlier, I have an open mind and instinctively would like to legislate earlier if there was a majority view in the Oireachtas that we should do that. So by the end of this year, what the map of Ireland from a structural point of view will look like will be published. From 2019, will begin to take effect on an administrative basis, and from 2020-2021 would be legislated for. That's my proposal, but it's very much, I think, in keeping with Sláintecare.
And thank you for that. And just to be clear on that, because the question that people in the HSC will be asking, just as they did when your predecessor, Minister Riley, said he was getting rid of the HSE, just as happened in the NHS when Andrew Lansley said he was getting rid of primary care trusts. The question people ask is, am I going to have a job? Because slimming down means there will be less people, which means some people will be on either voluntary or compulsory redundancy. That's what slimming down means, unless you go for natural attrition. And so we have a lot of very good people within the HSE. Are there layers of bureaucracy that shouldn't be there? Yeah, I think we're all agree there are, and similarly there are in some of the acute settings as well. But a lot of really good people will be watching this very carefully and thinking, okay, my job or my post may not exist in this new slimmed down world. When am I going to know this? When am I going to have certainty as to whether I do or I do not have a job in the new HSC? Do you have a sense for when they will know that?
So we're not there yet, and as you wouldn't expect me to say, I wouldn't be making any such announcements here in such a public forum, because these are conversations you have with representative bodies and the likes at an appropriate time. There is obviously a piece. This is about where people work. So many of these people work in the HSE today. Many people may work in a devolved regional entity into the future. The HSE obviously already has employees right across the country. So there will be an analysis done as to the needs of the health service. But I think this is something that you're talking about over a 2-year period or so.
Okay.
Before we know that. But the HSE, is very much involved in the implementation of Sláintecare. I want to make that clear. The Sláintecare is the policy direction for the HSE to follow, and it's one that they're very much embracing. But we will get this right. I mean, in the past, this wasn't always good, and this is genuinely not a political point. You've made the point about some of my predecessors. I'm not getting into naming people, but like when we did big programs of reform in the past, let's say the abolition of the health boards and the creation of the HSE, this is an area that wasn't gotten right. I think that's an objective comment. We have to get it right this time. We have to look at these things very sensitively and very carefully, and we're not in a knee-jerk fashion. We're talking about this being over a number of years, and it's probably, in answer to your question, probably around 2 years.
Thank you.
Minister.
Oh, sorry, Laura might just...
Oh, sorry, Laura, yes. Ms. McGahey.
Thanks, Chair.
Thank you, Deputy. Just, excuse me, in response to your question about assets and the sequencing of those decisions, I suppose that's what I'm looking at now between now and the year end. I've been tasked to take the series of 106 actions and to look at the dependencies between those actions. The way I'm thinking of doing it and rolling it out, over the number of years into the future is to use the construct of the Citizen Care Master Plan. So looking at the population needs on a geo-aligned basis, looking at the service design care pathways, then looking at what the infrastructure is needed and e-health needed to support that newly developed service design care pathways, and then critically to look at what the resourcing is, what the teams, that's why I'm calling it teams of the future, what those teams will look like, and the numbers, so that will take some time to sort out and do it in an orderly fashion.
And do you have a sense for when you'll be able to report on the forecasted needs in terms of workforce and physical assets?
I know that by the end of the year, I will have visibility of that.
Great, thank you.
Thank you very much. And just one issue before I go to Senator Burke and then Senator Durkan. Deputy Durkan.
The motion, I don't welcome it, but
could you outline what a Citizens Care Master Plan is?
Yes, absolutely. So I suppose it's if you were coming and looking and starting from scratch, which we're not, but in a way we almost have to say what would the ideal look like for planning the population increase from 4.6 million to 5.2 million over the next 8 to 10 years, which is what we're told. You would start with where is the population? What does it look like? What are their needs? What's the age profile? What's the deprivation index, and what are their requirements? And then you would build the service up around that population. I think it's been mentioned earlier, to do it that way, as opposed to saying, look, here's the buildings and here's how you have to respond to it.
So it involves population health. Population
health planning, exactly. So that's what the Citizen Care Master Plan is. But at the end, I would hope that we will have something that people can relate to, that the people can say this is the health system of Ireland, and they'll be able to actually look at it and understand how they can interact with it. So it's both a physical planning exercise, a service planning exercise, and a communications planning exercise.
And when will that Citizens Care Plan be available?
This will take time. This will take, I will come back at the end of the year to say how long it's going to take to do it, but this is not something that we're going to do in a matter of months. Yeah.
Okay. Thank you. Now, Senator Burke.
Yeah, thank you, Chair. My apologies. I had a commencement matter in Shannon and I was dealing with the Minister for Justice, so my apologies for being away for part of the meeting. Just Minister, in relation to the Project 2040 and the whole Sláintecare report and the whole where it has been identified that we need additional hospitals, and I suppose one of the areas that has been identified has been in Cork. And one of the issues that I'm concerned about is, I understand that there was a group of people established, drawn from all of the various agencies in Cork, from the City Council to the County Council to UCC to the voluntary hospitals, and also from the HSE. And my understanding, and the purpose of this group was to help identify a site, because I think identifying a site for a new hospital is a crucial issue. We've already run into 25 years of a delay here in Dublin in relation to Children's Hospital. And my understanding, while all of the people have been identified with over 6 or 8 months who should be on this group, that the HSE have made no effort to call the group together. And I'm a bit concerned about that, because, you know, one of the issues is identifying a site. The next issue is going through the planning process. And this is without committing really on budgets, but even a simple thing of identifying a number of sites and saying, well, these are the pros and cons of this site, these are the disadvantages, and so on. And I'm just concerned that this is a priority. The Cork city and county population has increased by 130,000 in that time, over 30 years. So it's gone from 410,000 to 542, and it is growing at a phenomenal rate. In fact, within the next, I'd say, 8 years, we could very well have a population of over 700,000 in that area. And therefore, I think this issue is a priority. So I'm asking that, first of all, whether or not your department can communicate with the HSE on this issue about, you know, we're talking about building additional units. At what stage do we start looking at sites? I'm a bit concerned about that. The second issue is in relation to over the last 3 years, we've taken on over 12,000 additional people in the HSE. We've gone from over 99,000 to over 110,000. And my concern has been is that the number of people taken on in admin and management, and I accept fully that they need support, but also if you now look at the whole cohort of people in the HSE, over 17,600 are in administration and management, and then we have about another 7,500 in nurse managers' roles. So that's technically 24,500, and I know in fairness nurse managers are also providing nursing services, but we seem to have this issue of having a management structure everywhere. And one of the problems I'm finding now with the HSE is that I can't get anyone to make a decision. I had a case recently where 12 people were summoned together drawn from the HSE and Acquired Brain Injury Ireland to make a decision on one person. So there are 12 people summoned to a meeting, and next 24 hours before the meeting was to happen, one person said, I've now moved to a new job in the HSE, I won't be attending, but didn't set out who would be attending in their place. As a result, the meeting was cancelled. I just find that astonishing. I've come across cases where medical practitioners are trying to make a decision. Out of courtesy, they report an issue to management that this is an issue they're dealing with. Next, they find they're being told by 3 different lots of admin people as regards how they should manage the particular patient. And I'm just wondering, and this is causing a huge problem with morale within nursing staff and hospital staff in hospitals, where no one can make a decision on a particular issue, and still, you know, and I raised this last week when Dr. Ulan was in dealing with the patient safety bill. While doctors and nurses are being held accountable at every step that they take, we don't have any accountability on the managerial side and as regards the decision-making process on managerial side and the delays in taking decisions. I mean, when was the last person on managerial side or management side in the HSE disciplined? Whereas doctors and nurses are being held accountable, and rightly so, where errors are made. And I'm just wondering, you know, what process do we set up to deal with that issue? If we want to have reform, and then the whole resistance to reform, how do we propose dealing with that issue? For instance, we had a meeting with Professor John Higgins last week from Cork. in relation to gynae services, and where we wanted to open the second theatre in Cork to deal with that. We ended up renting space from the Mater Private. The consultants moved down there to the Mater Private. Public patients were dealt with there in a very organised way, and over 1,500 people were taken off the waiting list. And that was as a result of the initiative by both management and by the consultants. But we seem to have had a problem in opening the second theatre in CUH in Cork to provide that service. So in other words, we had the space, we had the theatre, but we seem to have had a problem in dealing with it. I'm just wondering, if we want to implement Sláintecare, how do we deal with all of these issues that are going to arise as regards trying to get people into accepting that change must come about, and that also people must take responsibility in relation to the decisions that they are making, and that they also take into account the people around them.
Thank you very much, Senator Burke. Minister.
Thanks very much, Chairman. So just briefly on the three matters in relation to Cork and the Cork Hospital, I fully agree with Senator Burke that Cork is an area that needs increased capacity, particularly in relation to our acute hospital space. As you rightly say, the population has significantly grown and the bed base hasn't. That's why in the government's capital plan we announced not just an acute hospital development for Cork, but also that Cork would receive one of the three elective-only hospitals that I spoke about earlier in the context of the Scottish model and my trip there last week. I take the point that the Senator makes in relation to the next steps in relation to these capital projects, so in order to ensure that when capital funding becomes available in terms of its sequence in the plan, that you're ready to go, that you have the site, that you have the planning permission, that you're ready to go to tender, etc. What I will do in the next few weeks myself is I will convene the relevant stakeholders from Cork to seek an action plan in terms of next steps in that regard, and I'll certainly keep yourself, Senator, and other Cork Oireachtas members informed and updated in relation to that. On the issue of management structures in general, as you probably would have heard me recall earlier in exchanges with others, this is really at the very core of Sláintecare, is making sure that we have very clear identifiable structures in place at a regional level to get answers, and that's been lacking to date. So I do believe when we have the geo-alignment in place, where we have one integrated structure for the community and the hospital, so not the situation that you've discussed with me and other cases that you've brought to my attention, where somebody finds themselves stuck, for want of a better phrase, in a part of the health service, not being able to get to another part, where you've one integrated structure and a board, and a regional board, so you have the opportunities to look the decision makers in the eye and ask people to account for their actions. I do believe that will help. In relation to CUMH, I am pleased that we've significantly increased the investment to CUMH and also supported clinical autonomy in terms of their budgetary process in CUMH. They've made very big progress in relation to their gynae waiting list, and I want to thank Professor John Higgins. I want to thank the clinical team in CUMH for the work they've done in that regard. In the context of the budget and the funding for next year, I'd be eager to see if we can do more to support that good work to make further progress, and I'd be happy to discuss that further with you.
Thank you very much, Minister. So I'm conscious that we are going to have the Trinity team coming in, so we want to give them equal opportunity to discuss the Sláintecare implementation strategy. So Deputy Durkan and maybe Deputy Louise O'Reilly, you might combine your questions, and then we can allow the Minister to leave, and we'll bring in Trinity.
No, I don't.
Well, we're going to bring in Deputy Durkan first.
Very nice of you, Chairman. Very nice of you. Absolutely.
Next time I'm in the chair, I'll remember that.
I know there were a couple of points, Chairman, that occurred to me. There is a notion that, waiting lists have only occurred in recent times. That's not true. I remember dealing with cases in my own constituency in 2001, 2002, 2003 and 2004, where people were waiting on waiting lists for up to 7 years, and in one case 9 years, for a hip replacement, in extreme pain, in extreme agony, and had repeatedly tried to gain access to the service. So whatever was blocking the service that time, it blocked the service fairly seriously for people who were in acute pain. And some people during that period died before they received the service, and they died in pain. And that's a terrible reflection on the whole system at the time. So I wouldn't like the word to go abroad, you know, that this thing only started in the last couple of months or something like that. I disagree with my colleague, Deputy Stephen Donnelly, in relation to the abolition of the HSE. I think the Minister's predecessor was right, but he didn't go ahead with the next phase of it and replace it with the structures that were required. And I pointed that out to him, no secret at all, at the time. I believe that the HSE was the wrong structure. I believe it was the decision to replace the health board system with the HSE was the wrong decision at the time. But it was based on expert opinion that came from the UK around the Greater Manchester area, which had been quoted so many times to us, to the effect that the same population existed there and this could be replicated. Wrong. And some of us pointed out that it couldn't be done in that fashion because it was chalk and cheese. One with a vast geographic area here and the other one with a compact urban area that was ideal for delivery of concentrated services in the shortest possible time. So the sooner we recognise, in general, that we're dealing with a very different system to the system that operates in the Calderdale area in Manchester, the sooner we get along with it. There's one other thing, and I want to emphasise this again, and this is not rocket science. If you look at the control centres of big transport operations worldwide, they have a big screen in front of them, and they see the traffic moving live. And wherever there's a stoppage, and the stoppage is going to have serious consequences, they know what to do. Instantly, they know what to do. And if they don't do it, there are problems. The same has to apply to the health services in a different format, obviously. But unless we can identify the snags, the barbs along the system, where the system slows down, where access is denied to the patient. The HSE shouldn't be regarded as an employment agency. It should be regarded as a vehicle to deliver the service to the patient. And the patient is paramount, and the patient's needs are paramount. And if we don't recognise that all the talk we do, Mr. Chairman, and all the re-evaluation we do, and all the restructuring we do will come to naught. So the point I want to emphasise this, and I would like this to be borne in mind. The snags, when they occur, have a backup problem just the same as traffic. And it keeps getting worse and worse and worse. So my question is, what action do we take, and are we going to focus on that part and not of the weaknesses in the system? There are weaknesses in the system, there is no doubt. But if the system is only working part of the time, well, then we're not going to deliver anything. So the sooner we recognise that, the better, and we can play around with it all the time we like. And we can blame each other for it, and we do all sorts of things. Unless we develop a smooth, free-flowing system that keeps patients on that circular movement all the time, but get them dealt with in short space of time. So the question again comes back to it. What provisions do you have in mind to identify those snags for the individual patients and take action to deal with it? And the last point is in relation to overruns. Now, don't aggravate me and encourage me to go down that road. There have been overruns in the health service for the last 20 years, for God's sake. Unless overspends so the question that arises, which disciplines are affected most seriously? Which of the disciplines are the ones guilty of the overruns every year? So please identify those for us, and we then know exactly what we need to do in relation to that, or which number of disciplines.
Thank you.
Sorry, Chairman.
Thank you, Deputy Durkan. And Deputy O'Reilly, to conclude.
Thanks, Chair. Now, Deputy Durkan is right. Overruns are not new in the health service. Denying them is. Pretending that they're not recurring costs is. And as I said previously, I played a game of which of the previous governments made the biggest mess out of the health service. I played that all day, but it probably won't profit as much. Minister, I asked you a question about the overspend and the overrun and how that relates to recurring costs. Okay, so there is a difference, because we could have a once-off non-recurring event that would place unprecedented, and I'm not referring to the flu in this, I'm talking about something that could come and be completely unforeseen. So in the event that that happens, that's fine, and that's a separate issue. What we have are recurring overspends, and Tony O'Brien wrote to you about this very shortly after the budget. It was very early this year, actually, that you would have received that letter. So my question is a simple one. Do you accept that there is an overrun, and is it your intention to deal with that? I'm not asking you to divulge the fourth secret of Fatima or whatever it is you do for your budget negotiations. We read a lot of it in the papers anyway, and you'll be well aware of that.
It's as good as any other way.
But if you could maybe just acknowledge, was Mr O'Brien right, where his figure is correct? Is that the overspend that we are talking about? Is it that exact figure? Is it there or thereabouts, or is it worse? And is it your position that these are recurring overspends? They're not a single incident that placed unprecedented pressure. And I refer to the point made by Deputy Durkan, and he's right to say that the patients have to be the centre. Of course they do. But on the flip side, there is no health service unless we have people to work in it. There's just big empty buildings with a whole lot of sick people in it. So we absolutely need to have some sort of a strategy in terms of dealing with recruitment. Now, we might disagree about whether or not your strategy is failing entirely, or failing in part, or just not hitting the mark, whatever. But Sláintecare will require staff, and we do need to see that there will be some progress. And at the moment, what we have, we see the nurses are out in consultation. They've already signalled that this may lead to industrial action. I understand doctors and consultants are in more or less the same space. So while we're hemorrhaging staff, we have potential industrial relations difficulties that are mounting up here. All of this contributes to making it a very unattractive place to work. The purpose of Sláintecare, in some respects, is to ensure that those bright health professionals that are graduating, as well as those bright health professionals that are working within our system, and all of the other staff that keep our system going, that they see that there is a plan, and that they see that in time the HSE and the health service in general is a place that will be attractive for them to work in. Now, we had the very unfortunate incident where the numbers of student nurses were at, I think it was 435, and overnight that figure went to 870. So they had been counted as 0.5, and now they're counted as a full WTE. Now, that doesn't add one single solitary extra person, but it does make the figures look good, okay? But it doesn't add one single solitary extra body onto a ward. So I don't think we need to see any more of that. We do need to see some honesty about where the recruitment challenges are, and a detailed plan put in place. The Dáil supported the Sinn Féin motion on nursing recruitment and retention, and it was very clear in saying that pay has to be at the heart of it. We spoke to Kevin Duffy last week at the other committee, the chair of the Public Service Pay Commission. He said that he was explicitly told not to focus on pay, that it wasn't a pay review, but we can all pretend that pay is not an issue, but we're only ignoring the nurses, doctors and allied health professionals who are telling us that pay is very definitely an issue, not simply in the health service, but also in the Section 39 agencies, and I understand there was some progress on that, but also in Section 39s and others. So, and I would be interested to hear, and I don't wish to put Ms McGahey on the spot, because I know that you are only 22 days in the job, and but if you have any thoughts on how we are going to be able to, or you are going to be able to crack this nut, because there's no plan that will work without the staff to implement it.
Thank you very much, Deputy O'Reilly. So in conclusion then, Minister, and Ms McGahey.
Thank you very much, Chairman. So, look, I agree with a lot of what Deputy Durkan said. One of the things I think that we're actually lacking in the Irish Health Service, and it's why I think the Sláintecare Committee put such a focus on e-health, and it's certainly why I'm pleased that we're going to be able to deliver the e-health agenda in full, is the ability that e-health gives you to track exactly what Deputy Durkan says in terms of where is the blockage. So if you have a clinical director in a hospital who realises that there's congestion coming in the emergency department, that clinical director should be able to say, are there 20 people in beds who need an MRI or a CAT scan, and therefore if I get the CAT scan it'll free up to 20 beds. That inability to have all the data collated is a blockage in the system, and I think the e-health agenda is very important in that regard. In relation to the issue of the firstly in relation to the Section 39s, I very much welcome the agreement that has been reached at the Workplace Relations Commission, that will hopefully bring a stability and a certainty both to the staff working in the sector and obviously to those that they care for and provide services for. So I think that's something that we welcomed, and I want to thank SIPTU for their further engagement, led by Paul Bell, and I'm sure others in relation to that as well. On the issue of the overrun, that's the overspend, to So basically, just to give you a few figures, I mean, the estimates for 2018 provided for gross expenditure of 15.332 billion for health services. Of this amount, 14.839 billion is for current expenditure and 493 million is for capital expenditure. The last available position shows at the end of June that the HSE's income and expenditure position is €341.7 million above profile. Whilst obviously there is an offsetting of surpluses and deficits, a large proportion of the overall deficit, to answer Deputy Durkan's question, is in the acute hospitals division. Was the exact figure in Tony O'Brien's letter or anybody else's commentary? We don't know that because the year is not yet over. There will be an overspend. Let me say, I have said that on a number of occasions today. There will be an overspend or an overrun, whichever way you wish to classify it. It will need to be addressed. Myself and the Minister for Public Expenditure Reform are looking to address it. I hope that can be resolved in the coming days. I do just need to make one point though. When the HSE publish a service plan, there is a legal requirement under the legislation for the HSE to say we are going to deliver this plan within, and they know the funding available at that stage. So whilst I accept the point you're making, it shouldn't be, and you're not doing this in fairness, but it shouldn't be conflated, or sometimes it's easily conflated with the failure to deliver everything within a service plan. People have signed up to deliver that service plan in the knowledge of the funding that they have available, and legally have signed up to deliver that service plan as well. On the issue of nurses, I'll ask Ms McGahey to comment on the issue of Sláintecare and staffing and how she intends to address that. She did answer Deputy Donnelly on that a few moments ago, but just on the issue of nurses, I want to respect the processes the INMO and the PNA are undertaking. I don't want to say anything to interfere in their consultation with their members. I think it's important that that runs its course before I make more comments, other than to say this. There is particularly a retention challenge, recruitment and retention challenge, particularly a retention challenge, and I think that's what the Public Service Pay Commission found in relation to our nurses. We are putting forward proposals to try, in line with what the Public Service Pay Commission has said, to try and address those challenges. So the new entrant pay agreement, which will see newer, often younger nurses see their pay restored to an appropriate level and equivalent level to that of their colleagues. This is something that I think should be welcome for nursing, teaching and lots of other places, and pleased agreement has been reached in relation to that. We also want to see somebody be able to become a senior nurse quicker than is currently the case today, and obviously the financial benefit of that, and also the specialist qualification allowance. Nurses will have to make, and I'm not going to interfere in that process, an adjudication on those proposals. I know their executive and their EGM has made comments in relation to that. That needs to go through a process, and then we need to engage. Mr Duffy, the Public Service Pay Commission, does also say in his document that there may also be at some point in time, he doesn't specify a time, but there may also be a point in time where there should be further engagement. And he specifically references Sláintecare because, as you referenced, Deputy, quite correctly, to deliver Sláintecare is going to require healthcare professionals, including nurses, and may also require people taking on different roles, different tasks, working in different structures. So I'm conscious that that line is there in the Public Service Pay Commission report as well. I'd be eager to explore that further, but I'm respectful of the process.
That's interesting. Sorry, Chair, just very briefly. So, Mr Duffy has acknowledged that at some point in time, and that's grand. But would you not accept that that time might be now? I mean, the recruitment and retention crisis is now, and we're talking about things that we say are new, that aren't new, and waiting lists and all of that. Maybe they're new, maybe they're not, maybe they're worse now, maybe, I don't know. But the recruitment and retention crisis is new. It is. I mean, I know this. I represented nurses for years.
Sure.
We didn't have those challenges. Sorry, Chair.
Sure. So look, I accept, and I've said it in the Dáil, I've said it at the INMO conference, I say it here because it's the truth. We are having an issue, particularly with the retention of healthcare professionals. Recruitment, you can kind of argue that one because the stats will show people sign up to be nurses, sign up to be doctors. The length of time people stay in the health service, the retention piece should be a cause of concern. Mr Duffy and the Public Service Pay Commission have made some more general comments, including the one I've referenced in relation to Sláintecare, but they've also made some very specific commitments that we want to extend to nurses in relation to the qualification allowance and the senior nurses scale. Coupled with that is the new entrance piece. I'd like nurses to obviously consider that in the context of their discussions, and then obviously when they've had the outcome of those discussions, I look forward to engaging with them.
Thank you very much. So, Ms McGahey and Minister, thank you very much for coming in this morning to discuss the Sláintecare implementation strategy. And I'm sure we will be meeting you again in the medium future.
We look forward
Thank you very much.
Thank you, Chairman. Thank you.
We're now going to suspend for a few moments to allow our next group of witnesses to take their seats. In this session, we are meeting with representatives from the Centre of Health Policy and Management at Trinity College in order to get the Centre's view on the Sláintecare implementation strategy. So I would like to welcome Dr. Sarah Burke, Professor Steve Thomas and Dr. Bridget Johnson. Thank you very much for coming. I wish to draw your attention to the fact that by virtue of Section 17(2)(l) of the Defamation Act, witnesses are protected by absolute privilege in respect of their evidence to this committee. However, if you are directed by the committee to cease giving evidence in relation to a particular matter and you continue to do so, you are entitled thereafter only to qualified privilege in respect of your evidence. On behalf of the committee, I should have this off by heart. You are directed that only evidence connected with the subject matter of these proceedings is to be given, and you are asked to respect the parliamentary practice to the effect that, where possible, you should not criticise or make charges against any person or persons or entities in such a way as to make them identifiable. I also wish to advise that any opening statement that you make to the committee will be published on the committee's website after the meeting. Members are reminded of the long-standing parliamentary practice to the effect that they should not comment on, criticise or make charges against a person outside of the Houses or an official either by name or in such a way as to make him or her identifiable. Can I now ask Professor Thomas to make your opening statement? Thank you.
Thank you, Chair. Thank you, Deputies. Yes, thank you very much for your invitation to appear today. We are delighted to be here. I'm accompanied by Pathways team members Dr. Sarah Burke and Dr. Bridget Johnson, whose assistance has been invaluable. You have asked us to evaluate the Sláintecare implementation strategy and present our work on rephasing the original Sláintecare costings. This research was presented at the final seminar of the Pathways to Universal Healthcare project, funded by the Health Research Board, which took place a week ago in Trinity College, Dublin. It also draws on our experience of working with the Oireachtas Committee on the future of healthcare at the end of 2016 and early 2017, where we had the privilege of working closely with some of you. The Sláintecare implementation strategy was published on the 8th of August 2018, and Laura McGahey began as the Executive Director of the Sláintecare Programme Office in September 2018. The Sláintecare implementation strategy has 4 goals and 10 interlocking high-level strategic actions, each of which have further specific actions. A brief critique of the Sláintecare implementation strategy follows, using the framework which structured the work of the Oireachtas Sláintecare report. In this, we compare the treatment of vision, principles, entitlements, integrated care, funding and implementation in the Sláintecare implementation strategy with the Oireachtas Sláintecare report. Vision and principles. The Sláintecare implementation strategy refers regularly to the Sláintecare vision and restates the principles contained in the original report. The Sláintecare vision, as specified in the Oireachtas report, was a universal health system accessible to all on the basis of need, free at the point of delivery or at the lowest possible cost. Entitlements. The Oireachtas Sláintecare report defines what it means by universal healthcare and outlined what services were to be included in a universal system. It specified that all residents would be entitled to these services, that this entitlement would be backed by legislation alongside a wait time guarantee, so everyone in Ireland would be entitled to a full package of services, free or at low cost, within a set period of time. It detailed the phasing and costings required to deliver such care. The Sláintecare implementation strategy is much more conservative, referring to eligibility rather than entitlements. Action 6 is to expand eligibility on a phased basis to move towards universal healthcare. It uses the term universal eligibility, which is at worst an oxymoron and at best only a conditional commitment. It goes on to state, our vision is that all citizens will have access to universal healthcare in both acute and community settings, and these statements appear contradictory, either implying a lack of understanding of the terms or a watering down of the commitment to universalism as laid out in the Oireachtas Sláintecare report. Integrated care. The Sláintecare implementation strategy upholds the vision of integrated care as specified in the Oireachtas Sláintecare report. In particular, an imminent decision on the alignment of community services with hospital groups, as well as the allocation of resources through regional integrated care structures on the basis of population health need, are both positive aspects of the implementation strategy. Funding. Goal number 3 of the Sláintecare implementation strategy is to ensure that the health service is financially sustainable. It has a strong emphasis on productivity and achieving value for money. However, there is no recognition of household financial sustainability, little about eliminating or reducing charges, and no national health fund as specified in the original report. There is a specific action to design, establish and resource a multi-annual transition fund with appropriate governance to support the change process. While the capital aspects of the Oireachtas report transition fund are included in the National Development Plan, in terms of community diagnostics, e-health, primary care centres, new hospital capacity and elective-only hospitals, there is no mention of the funding required to train increased numbers of health professionals for strong primary and community service, as detailed in the Oireachtas Sláintecare report. Neither is there any specification of the additional money required to fund the expansion of entitlements and to support the reform process as specified in the Oireachtas Sláintecare report. The Pathways team have reworked the Oireachtas Sláintecare cost projections to provide another option for funding. This extends the implementation period to 12 years and elongates some of the phasing of specific components within that. And we would be delighted to show you some slides of these after this opening statement. Implementation. Goal number 1 of the Sláintecare implementation strategy is to deliver improved governance and sustain reform through a focus on implementation. This puts implementation up front and centre with a map of the Sláintecare implementation structure. However, the implementation strategy critically lacks the specifics of the original Sláintecare Oireachtas report in terms of targets, phasing, timelines, milestones and the budget needed to deliver it. And it is important not to reinvent the wheel. In conclusion, the publication of the Sláintecare implementation strategy, the appointment of Laura McGahey and the establishment of the Sláintecare Programme Office are all necessary and important developments. The Sláintecare implementation strategy begins to do the important task of weaving together reforms that were happening anyway with the Sláintecare reforms. However, there is a need to keep an eye on the Sláintecare Oireachtas vision and ambition and the essential components of entitlement and funding which are lacking in the implementation strategy. Nevertheless, the strategy progresses the Oireachtas Sláintecare report by integrating clinical and corporate governance. The emphasis on public engagement on health and well-being, a workforce engagement plan and the development of a citizen care master plan are welcome additions and may well be critical to triggering the political commitment and leadership that is needed to fund and deliver the vision, as laid out in the Oireachtas Sláintecare report. And we look forward to further discussions with you on this matter.
Thank you very much, Professor Thomas. Did you want to go through your slides at the beginning?
Why not? We'll throw that in, if that's acceptable. Okay, so what myself and my colleagues now will try and present to you is a few of the slides that we drew from last week's end of project workshop on the Pathways to Universal Healthcare. And we've just selected these out because they might be useful to focus on. So if you want to hit the first slide, thank you. So one of the issues that's come up with Sláintecare is that is it too expensive to implement? And obviously one of the questions is whether it's too expensive not to implement given the current overruns in health funding. And the original Sláintecare report was basically focused on a 10-year implementation plan a lot of the activity, particularly around entitlement expansion and the transition fund, was front-loaded into the first 6 years, with a maximum amount of 460 million expansion related to entitlements per year. I think that's probably in about year 3. So one of the questions we looked at is, what if we change some of the assumptions behind that? We still keep the basic costings then, and we still keep the basic items, but what if we shift some of the underlying assumptions to look at a 12-year implementation plan? We don't front load it into the first 6 years, but we spread it out more evenly across the time. We push back the start dates of a couple of items, for instance the inpatient hospital fee removal to year 2, and the emergency department fee removal to year 11 from year 8. And we stretch some of the phasing, particularly around universal primary care, which is now elongated to 6 years implementation rather than 5 years. And then with the GP care, with the freeing up of GP care and the replacing private income in public hospitals, we look to both phase those back a bit and stretch the phasing in order to get our house in order for preparing and implementing those particular policies. So we try and change some of the underlying assumptions, and so it's interesting to then look at what impact that has. So I show first of all, I show here on this bar chart with the particular bars, the entitlement expansion costs required for each year, and that's shown on the left-hand axis. And so we're running at about 250 million for the first 5 years. I'd like to point out that actually by the end of the 12 years we still arrive at the 2.8 figure, which is shown by the line chart, and on the right axis there you can see the total amount coming to around 2.8 billion. So that's still consistent with the current entitlement expansion that's detailed in Sláintecare. But that gives you a slight idea of the rephasing. And if we go to the next slide, you can then basically do the comparison with the original Sláintecare costings in the orange and the revised and rephased Sláintecare costings in the blue. So you can see there that we have substantially less required up front, but then at the tail end there's more investment, so it's more evenly focused. And the next slide. We can also do this also for the transition cost too, because if we have the 12 years rather than the 10, and we are elongating the phasing or delaying the phasing of some of the components slightly, we can also redistribute some of the transition costs too. And the impact of this is to reduce some of the initial burden on the budget. And the interesting work done by the Nevin Institute, by Neri, was that particularly for year 1, there may be budget constraints, but subsequently there was enough money, fiscal space to actually implement Sláintecare. And this way of rephasing may be a way around getting some of the initial problems with affordability. So I shall. Do you want to talk about that one, Bridget?
Yeah, absolutely. So following on from this part here about the affordability and sustainability from a financial perspective for the government, is how affordable is healthcare for households with the current model and the way we're funding it. So currently about 70%, 68 to 70% comes from general taxation, and the remainder of funding comes from private health expenditure. So that's what households either spend out of pocket at the time they are accessing healthcare, or the reimbursement that comes from private health insurance companies back into the system. And they contribute about an equal pot each, about 15% each within, so half and half. Some of the work I've done for the Pathways project is to look at the affordability of this spending specifically that households have. And using the household budget survey provided by the Central Statistics Office, I've been able to estimate that about 14% of households were not able to afford what they were spending on either out-of-pocket charges or private health insurance premiums in 2009 and 10. By 2015-16, this had actually grown to 17.3%, and that probably should be seen in the context of rising charges throughout multiple budgets, but also the increase in private health insurance premiums. But what's interesting to look at here on this slide is who's mostly affected by this. So what do these households look like? What kind of protection are they supposed to have from the system already so that they don't experience this financial hardship? Now, what we can see on the top bar, looking at 2009-10, is that the majority are medical card or GP card holders. That's the brown. But blue are considered double. So they have not only a medical card, but also private health insurance. So these are people who are meant to be protected by the medical card system as well. And we can see that they're the overwhelming majority of people who are not financially protected, who are experiencing financial hardship, who are being pushed further into poverty or into poverty because of their spending on either of these items. And then we can see that this grew substantially by 2015-16, not only proportion of households, but that breakdown within. So again, we can see that the safety net that's meant to be provided by the medical card scheme is not doing that for a household. It's the overwhelming majority of those who are experiencing financial hardship. So in current form, this system isn't protecting people as well as it should.
Thank you very much, Dr. Johnson. So could I just start then? I just ask you the same two questions I asked the Minister when he came in this morning. The first was in relation to political buy-in. We had a long discussion in the Sláintecare committee about where the Sláintecare implementation office should sit, and it has been placed in the Department of Health. We were very strong that it should be placed in the Department of the Taoiseach. So maybe you might make some comments on that, and where does that leave us in relation to political buy-in? And the second question I put to the Minister was there was no reference to a National Health Fund in the Sláintecare implementation strategy. And again, that was a huge component of the Sláintecare plan, that there would be a National Health Fund which would be made up of taxation and earmarked taxes and earmarked specific funds which would make up that fund. And the Minister has answered that by saying that the funding for Sláintecare will come through the normal budgetary process. And we were quite strong that that was not going to be sufficient funding to implement Sláintecare. So perhaps you might make a comment on those two issues.
Okay, maybe
Very good.
take the first one. Is it? Or,
Yeah, that's fine.
okay. I think there's two separate issues there, Michael. One in relation to where the implementation office sits, and two in relation to political buy-in. And obviously I was present for lots of heated discussions privately with the Future of Healthcare Committee in relation to where that implementation office should be. I actually all along was in a minority and favoured it being in the Department of Health, because I believe very strongly that the Department of Health is there to drive the strategic direction of health policy in Ireland. And if the department isn't driving Sláintecare, then what is the department doing? So I think it's a positive thing that the implementation office is in the Department of Health. But I also think it's critical that there are structures in place to support that work and political buy-in. I think the implementation strategy has done a pretty good job with that map of what the governance structures are for Sláintecare. And I think the fact that there's this high-level committee with deeper in the Department of the Taoiseach, that it's reporting into the Cabinet Subcommittee, has an independent advisory group, are all positive developments. So I think that's a strength of what's happened since the work of the Future Healthcare Committee. I think there's a separate issue in relation to political buy-in. And I think it was very evident from Minister Harris' presentation this morning, he's wholeheartedly behind Sláintecare. But I think there is an issue as to how far that political buy-in goes. And I think there are political hearts and minds to be won across the Oireachtas, actually, not just in the government, in terms of support from Sláintecare. But the international evidence is really clear on this, that unless we have political buy-in from the Taoiseach down, and particularly from finance and deeper, so Pascal Donoghue having a key role, then Sláintecare, it's very difficult for Sláintecare to happen.
Thank you.
Okay. And then I will take up the second question on the National Health Fund. I think it's very difficult and probably without precedent to get the current tax base to deliver sufficient resources for the scale of change required to transition the system and to reconfigure it. And I think there's a very strong case for making a one-off investment in reconfiguration. And as we've seen, even though there's elements included in the capital plan, there's still important elements of that new system around primary and social care professionals, which is lacking. And I think the danger is that with tax, you will always get squeezed out. We even see the overrun issue coming in, that there'll be a squeezing out. And so if there isn't a protection, if there isn't an earmarking, and it's very difficult to protect the necessary space to do that. And there probably needs to be a conversation with the general public about that, about the earmarking of a particular tax into that fund, allocated out for these reconfiguration purposes and for these entitlement expansion purposes. Otherwise, the danger will always be that it gets crowded out. However laudable the ambitions, the danger is it will always get crowded out by the immediate.
Okay.
Just one brief further comment on it, that I think we hear a lot about how Sláintecare needs to be funded within the usual annual budgetary frameworks. And I think actually that says a lot about the absence of political buy-in, because if there was political buy-in at the most senior level, they would get that this can't be done within the annual budgetary process, that it needs an additional, not just multi-annual funding, but this transition fund to shift the provision of healthcare in Ireland.
Thank you very much, Dr. Burke. So now,
you can call me Sarah, Michael.
Sorry. Okay.
If that's in terms of procedures.
Of course it is. Can I ask Deputy Stephen Donnelly to make his contribution? Thank you.
Thanks, Chair.
We'll go through the same format of forwards and back for 7 minutes, if that's okay.
Thanks, Chair. Thank you all for that, and thank you for your very considered review. It is worrying. I mean, you are forthright, and you have called out the areas that you have worries about. I'm going to make one nakedly political point, which I don't expect you to respond to, but it's relevant to implementation, and then I have 4 questions. The political point is this. I think healthcare has been extremely badly managed over the last few years at a political level. I think a lot of that is down to poor implementation, just the ability to get things done on the ground, the ability to open up an ICU bed here and there that's required, the ability to make sure that a surgeon gets hired where they're needed and so forth. And I see that incompetence, my view, not yours, I'm not transposing my views, but I see that incompetence rolling into implementation in Sláintecare, and it does worry me. My 4 questions are as follows. The public don't really care about Sláintecare. It's a reconfiguration strategy. It's very important for the future of healthcare. Fianna Fáil is fully signed up to it, but the public don't care. The public care about getting access to medical care, be it in their home or in their local GP's clinic or in a primary care centre or in an acute setting or in a rehab setting or wherever it is. And there's a danger that as the focus moves on to this sort of shiny and extremely complex and difficult healthcare transformation, that actually the most important thing, which is about getting boys and girls and men and women access to doctors when they need it, that slides. Could you point us to what you believe are the most important implementation aspects that you think will increase access / reduce waiting times quickly? Because actually that's what the public need. That's what people are screaming for. The second question is around universalism. Universalism, or universal healthcare, is defined as an ability to access healthcare without incurring undue financial hardship. And Sláintecare is sort of ambiguous on this. It talks about universalism, which does not necessarily mean free, but it also talks about free. And it sort of interchanges those a bit. Your assessment suggests you've raised serious concerns about universal access. Can I ask you, do your concerns relate both to free access and to universal access as the WHO defines it? In other words, you seem to be saying you are concerned about the future ability for people to access healthcare for free. Are you also concerned based on what you've seen, about their ability to access healthcare without incurring undue financial hardship? Would you be concerned regardless of which definition one uses for universal? My third question is, it's not really covered in your assessment, but I imagine you'll have a view on it, which is, I've done healthcare reform abroad, and the single most important thing for healthcare reform to work, assuming you broadly have the right direction you want to travel in, is the buy-in of doctors. It's the single most important thing. If doctors aren't bought in, particularly senior clinicians, healthcare reform tends to fail. The doctors and their unions are pretty scathing of Sláintecare, and these are public statements they've made. There may be individual doctors, I'm sure there are, who are bought into it, but at an organisational level they have been heavily resistant to Sláintecare, which is something that has to be addressed. Have you any thoughts, reflections, advice for us as an Oireachtas in terms of trying to achieve buy-in for Sláintecare and this implementation at a senior clinical level? The final question I have is on the costings. Thank you very much for the ones you've done. As I read your slides, you've done two. You've done the cost of expanding entitlements as one piece, and then you've done the cost of the transition, and both get to about 3 billion thereabouts. Have you done an analysis that is the total cost? So includes the cost of entitlement, the cost of transition, the cost of scaling up, and any other costs. Do you have a total? So getting to your point, Sarah, around there's either buy-in for this or there's not, and if there is buy-in, then people are thinking at a very serious level about deploying very serious resource against this, and I'm not seeing that from finance, I'm not seeing it from Taoiseachs, and I'm not seeing it from health either. But what would be very helpful is a total figure. How much do we really need to be pouring into this, either against the original Sláintecare profile or indeed your revised, slightly less front-loaded one? Thank you.
Thank you very much, Deputy Donnelly.
Yes, which to choose? Let's start with the last one first. We did actually shortly after we helped with the production of the Sláintecare report, we did an overall costing of what does it all add up together, and it comes to the heady total of around, I think, 19 billion, but that's over 10 years. So that's got to be taken in the context of likely public expenditure of around 200 billion in that context. So if you throw 19 billion around, it starts to get kind of scary, but the fact is that actually within the context of 200 billion, that's actually not that big a price ticket, given that then you're then engaging with whole-scale reform to the system and universalisation and an expansion of entitlements. The reason why we don't present them together is in the costings is they're slightly different things. On the first one, it's what is the annual increment in entitlement expansion, and on the transition fund, this is the actual amount that you spend. So it's they're slightly apples and oranges. But yes, it's probably around 19 billion, I would say. But again, that has to be put in the context of the overall spend. So that would be my comment.
And sorry, just on that, do you have a year-on-year profile of that 19 billion?
I could certainly give it to you.
Could you?
Yeah.
Great. Thank you.
I could make it available to the committee.
Very good. Thank you.
Yeah. Thanks. Fine. Okay. Volunteers.
Maybe I'll do the second last one then next, which is the point you make around how important it is to have medical professional buy-in. You talk specifically about doctors. Yeah. In fact, that's very much changing international now, and the literature is around healthcare professionals and clinical leaders who aren't necessarily doctors. So a really good physio or OT can be just as important a clinical leader as a doctor. And there absolutely is a strong literature around that, and you need them. But there is also a very strong literature around how doctors in particular are often the ones to oppose any type of reform. And actually, once you begin to do it, most of them come on board. But I think there is a significant piece of work to be done by the Implementation Office around engaging clinical leadership, not just doctors, so all healthcare professionals, all clinicians across the system to come behind this plan. And I don't think that's been done yet, and it's why we've specified in our opening statement that the aspects in the strategic implementation strategy around public engagement and workforce engagement, and particularly clinical engagement, and that integrating the clinical and corporate governments, are really key parts that have been missing from the Oireachtas process so far. So I think that really needs to happen. But I would think, you know, most people go into clinical work of some type or other with the intent to look after and care for people. And most people out there in the system find their jobs extremely difficult at the moment because it's really hard, because there's all these, it's like survival of the fittest. It's an obstacle course to provide the best quality care. And I think if you can demonstrate to the workers providing that care that this is going to be better for the people who use the services, that you could get them on board. You can get most of them on board too. And maybe briefly that'll bring me to your first one, which was around the most important implementation aspects around increasing access and reducing waiting times. And in a way, there's two questions in that, so I'll deal with the increasing access. I think you've got to begin to do stuff. You've got to show to people the difference that it will make in their lives. And a huge part of Sláintecare is shifting care outside of hospitals into the community, so much, much better, critically primary and social care. So everybody, not just people with medical cards, needs to be able to access those services without a long wait time, but also critically without a charge. Now, whether that's free or low cost, it can be determined, but most of the literature supports the no cost rather than a low cost element, particularly if you're trying to get people to go, you use it as an incentive to use those primary care services. So I think stuff that was in the original report, like universal child health services, really, really good early intervention child health prevention work, universal palliative care, really good care for people when they're dying. That if you use those aspects, you begin to get buy-in from the population. And I actually think you're wrong. I don't think the public know about Sláintecare, but I think if you begin to go out there and talk to people about what do they want about their health system, then you can actually get them on board.
Which bit am I wrong on?
You said you don't think the public cares about Sláintecare or wants Sláintecare.
No, the point I was making was Sláintecare, nobody knows what it is. They're not interested in this. The point I'm making is they need the results.
Exactly, exactly. So they need to experience Sláintecare they need to know Sláintecare by experiencing it, whether that's cutting down on some of the charges, and perhaps Bridget can come to some of this stuff around whether it's free or low cost. But it needs to become a reality for people. And I think actually the vast majority of people care hugely about accessing timely, quality health and social care services. And you can get them on board for Sláintecare.
Yeah, sorry, that's exactly the point I'm making. I don't think you need to get... The public don't need to be on board for Sláintecare. Sláintecare is a reconfiguration plan. You need clinicians, you need the HSE, you need GPs. What the public want is timely access, timely and affordable access to high quality care. And so just to that, I take your point on, you've a view that it's important to make Sláintecare real to the public by reducing costs. I'm asking a slightly different question, which is the waiting lists have now got so bad that people are dying on waiting lists waiting to see doctors, right? That's happening. I am meeting the parents of children who are literally dying because they can't get access to surgeons, right? So that's the reality today. In Cork, a child will wait 3.5 years to get access to special needs intervention. Urology in James's is now a 6-year wait to see a specialist, just to see one, and it's getting worse and worse and worse. So my question on Sláintecare is, I take your point. I don't fully agree with it. I take your perspective on you make Sláintecare real for the public by sort of reducing financial barriers. I think we've got to make it real for people by cutting down these completely unacceptable waiting lists. And so I guess my question is, do you see specifics in there that would very quickly begin to address the waiting times?
Thank you very much, Deputy Donnelly. And we do want to move on, so maybe a 1-minute answer if that's possible.
Okay. I think the critical issue, as you say, is making sure that the care is available when people need it. And there is a strong commitment in Sláintecare for the wait time guarantees. And the evidence is from other countries who brought down their waiting times quite significantly, is that you do need some kind of mechanism or guarantee whereby people then get an entitlement to care. Now, whether that's through strong accountability, as in the NHS, or whether it's through vouchers in Portugal. There are different ways to do that, but unless you have that accountability so that there is a guarantee of care, then the system doesn't shift, no matter how much money you put into it. Right. So there is a system reconfiguration is necessary, but it's not sufficient. So you need that culture of accountability, and you need a culture of much more information availability, I think, on waiting times rather than just waiting lists, which we don't currently have. So good information on that, much more accountability to the public about what's actually going on, how long their waiting times are, much more accountability on the performance of different providers. So I think you need to build that in. That's a very strong component alongside the system expansion stuff. Do you want to just say something quickly on the financial?
Absolutely, financial protection, because it's linked in with this access question. So obviously, we saw that bar chart with the double insurance holders. Essentially, they're insured or covered by the public system by having a medical card, but also continue to pay out of pocket for private health insurance. And even those who don't, we see a large proportion of that spend that's not affordable is accessing private care. So people can't wait on the lists. So it's not just an issue of making it more affordable and reducing those charges, but also making sure that people feel well looked after in the public system and they're not paying in a way they can't afford. But Sláintecare is very clear. It says that the care is either free at the point of delivery at the lowest possible costs. And there have been a number of charges introduced in the last number of years that bring medical card holders in particular into the fee-paying fold, when we've already designated these households aren't able to afford them. And when we look at the comparison across the years, we see that it's these charges for prescription drugs that are really driving a lot of the very unaffordable spending for these poorest and most vulnerable households. So it is important to make sure that the most vulnerable households aren't paying for care that they can't afford. That is a significant part of their experience of accessing health care. It prevents them from filling their prescriptions and adhering to their medication. It is a very serious problem that we need to address. But also, at the lowest possible cost is very clear in Sláintecare. We don't talk about removing the drug payment threshold. We talk about lowering it to more affordable thresholds. So there isn't this sense of free care everywhere. We're an outlier in a European context where we don't offer free primary care. People either have basically free care to the GP or they pay the full cost of it. And even within the GMS, we know that patients are paying for signing off on their disability forms and other small charges to primary care providers at the same time. So we need to ensure that this system, this safety net, is actually doing what it's meant to do.
Thank you.
Thank you,
Chair.
Bridget. Now, Deputy O'Reilly.
Thanks, Chair, and thanks to you guys. I'm sure when we finish doing Sláintecare, you all sort of collectively hoped you'd never be in this room again, and there you go, here you are back. I'm not going to ask you to comment on that, Joe, far too nice. I will make a political point, though, and my colleague has made one, so I don't normally, but I will join in. I do welcome the Fianna Fáil commitment to Sláintecare, because when we launched it, the strongest commitment we got was that it would be brought up at the parliamentary party meeting. And I think the real test of it is going to be what comes out of the confidence and supply negotiations on the budget, and we'll see. We'll see. No, it's not actually, because I was there. And it's not. It's not. And we were all in the AV room together, so I'm not the only person that thought. With regard to, and my questions are, with regard to the legislation, the Minister, when he was here just beforehand, was very my view of it is the legislation comes first, and the legislation to entitlements is the driver that drives the resources and drives all. The Minister appeared to be putting the other way around, so that basically when everything else is in place, then and only then are we going to be in a position to legislate for maximum waiting times and legislate for entitlements. Now that to me goes against some of what we would have discussed during the course of our deliberations, and I'd just be interested to hear your view on that. My view is if we wait and we keep waiting and we keep waiting and we can't get the legislation till everything is perfect, everything will never be perfect, and then we'll never get the legislation. So, with regard to the recruitment and retention, I think there is an issue with Sláintecare. It's certainly backed by the Irish Congress of Trade Unions, which obviously being the umbrella body for most of the workers, I think about 90% of the workers within the health service. They have a view that the Sláintecare will be a key factor in recruitment and retention. They have other views because they're trade unions, so a lot of that focuses around pay. But just with regard to service delivery, they back Sláintecare as a basis for dealing with the recruitment and retention crisis. But we had the Minister and Miss McGahey in front of us just before you guys, and they didn't seem to have anything new in terms of recruitment and retention that they could offer in terms of how we're going to attract. And it refers to the point made earlier, if we don't get buy-in from the healthcare professionals, we aren't going to be able to deliver it. So there are steps that I believe can and should be taken by the powers that be, specifically by government and cabinet, that will show us that there is a commitment, because the general public may not understand the intricacies of Sláintecare, but they know what a waiting list is. They know when they can't afford to pay for prescription. They know when they're standing in the chemist and they have to make a choice between two medications that they need, but they can only afford one. They understand that. And I'm just curious if you would have any ideas on what can be done at a high level to instil that confidence that might drive some recruitment and retention. By the way, I don't think it's going to drive all of it, but it might drive some level of recruitment and retention, and it might also improve the buy-in from those groups where there isn't necessarily buy-in. So nurses, healthcare professionals and doctors via the IMO, I think, are substantially bought in. There's issues that they don't love in it, but I think they have some buy-in to it. But there is clear hostility from other groups, and I think that some of that comes from maybe they have reform fatigue, perhaps that could be. But I'm just wondering if you guys would have a view on how that can be driven at a high level to ensure that we get the buy-in from the healthcare professionals. Thanks, Chair.
Thank you very much, Deputy O'Reilly.
Okay.
Steve Thomas?
Yeah, I could speak to both, but any strong?
I could take a start on the first one and hand over to you if you want, or you want to go for it?
Yeah, I'll go for it.
Okay, you go for it.
Because I think the actual answer to both is sort of are the quick wins in the system, actually. And these are deliberately built into Sláintecare, which is one of the nice things about it, is that you have wins that you can do without system change. They just make a difference to people's lives. Lowering the prescription charges, removing hospital inpatient charges, lowering the drug reimbursement threshold for single-headed households. Those are all overnight wins that you can do, and therefore we don't need a system response, and therefore we don't need to wait for the system to change for some of the aspects. And I think, so that whole issue of do we need to wait around for the system to get better, to be legislating, no, I don't think we do, because there's stuff that we can do now and we can get in play now. Now, there are components whereby it's a slower build, and you need to develop a universal primary and community care setting. I think that's a key issue. And so I think having quick wins builds trust with the public. I think investing in the right areas around primary and community care hopefully builds trust within the providers within the system, because they can see where it needs to go, that we're far too acute focused and we need to have a much better non-acute setting. So if we're investing and we're putting, as we talked about earlier, human resources into that setting, making sure that we can make good on some of our commitments there, I think people start to see a system that's changing that they can buy into, and that's, I think, when it starts to build motivation and morale. So I shall stop there.
Thank you. Just in relation to the first point you made, Louise, around them shifting the cart before the horse or whatever, I would agree with you, and we presented some of this last week at our seminar in terms of, and from my read of the strategy, Action 6, which is around universal eligibility, which isn't a term anyone's ever used before, because it's about entitlements rather than the point you made earlier to the Minister. And what it does is it talks about reviewing charges, reviewing current eligibility framework, developing a policy proposal, and then introducing legislation with no timeline beside it, when in fact Sláintecare put very clear timelines on legislation and phasing and introduction. So I think it's a step back in commitment rather than a step forward, but it was good to hear the Minister talk about entitlements this morning. And likewise, the Action 9, which is in relation to the workforce. I guess if you could suggest that they're slightly Sir Humphrey sections of the implementation strategy, in that they go on, but they don't give us too many specifics on how to actually move them forward. And perhaps that's where the politicians can come into it in terms of firming up some of those actions to have better commitment in them.
Thank you. Thank you very much. Sarah Burke. So, Deputy Durkan, do you want to come in next?
Yeah. Thank you, Mr. Chairman, and I welcome our guests this morning and thank them for their presentations. Can a reference to be made to training an increased number of health professionals? And we agree. I think we all agree on that. The degree to which that can be achieved in the short term, and with particularly in retaining them, is something that we're not so readily agreeable on, because we don't really know how to do it. It hasn't been shown to us yet. And we are competing on the world market for health professionals now. Yes. And the question that arises immediately is an economic one. Can we afford to compete at the level required in order to attract the appropriate number of professionals into the system here? I would remind people during the Sláintecare sittings, I was at pains to point out the battle that goes on within each government department for resources at budget time. And always there will be a suspicion amongst other departments if one department is being given priority. The good part of this is that the Office of the Taoiseach is involved, which will give an overview to everybody involved and a recognition that there are pressing issues in this particular area that need to be dealt with. But there are also pressing issues in other areas, equally pressing, in the area of education, in the area of housing. The three areas we're fighting for the same resources. And to what extent do you feel, and you can answer the question if you wish, do you feel that it is feasible to marry the three departments together in such a way to ensure that they can coexist in a complementary way? Because there is an element of, especially in the housing area, of being complementary to the health services in numerous ways. The cost and affordability of housing for the health professionals, the cost and affordability of housing for the patients, for everybody, for everyone. So I just comment there. Cost versus vision and entitlement, that's been you referred to that, and rightly so. To what extent do you see progress being made towards achieving the vision and at the same time balancing that with the availability of resources as now becoming available? And also keeping in mind that despite the fact that very, very considerable strides have been made in turning the economy around, and the public and the government and politicians in general have made a major contribution to that, and it was at great cost to the general public and everybody in general. Do we now see a situation whereby, for instance, we still have national debt, very considerable debt, and considerable servicing of that, something in the region of 6 billion per annum, which has to be brought into the equation as well. So my question really is, do you see it feasible to weave a path between all of those competing issues in a way that will achieve the results that we desire in Sláintecare?
Thank you very much, Deputy Durkan.
No pressure on that question, eh? So I shall take the first one to start with. I think I totally take on board Deputy Durkan's comments about training. I mean, it takes time. Human resources are always the slowest thing to build, and they're the most essential ingredient of any health system to work well. And we know we are deficient, particularly in primary and community care, where actually we didn't do so well during the austerity years. We lost more professionals from that area than any other area, and we've recovered less well as well, whereby there's been more recovery in human resources in the acute settings. So yes, it is very important. It's deliberately phased during Sláintecare, and particularly if you then look at some of the elongated phasings that we looked at, then that gives you even a little bit more time. But I quite agree. We have to think, what is it that motivates people? What is it that will help recruit and retain people? And the international literature shows strongly that it's quite a broad package of different things. So salary is one thing, but salary is rarely enough by itself. You need to look at training possibilities. You need to look at hospital environment. You need to look at good management. So there's quite a broad package of different things which help people become satisfied. So I think we need to pay attention to that, particularly where some of our policies have whilst we've managed to import our way out of some human resource challenges, we've often lost people who've moved on, because actually when it comes down to it, the terms and conditions haven't quite worked out that well, or there hasn't been enough training opportunities. People have felt they've been in dead-end positions. So that's clearly something that needs to be looked at very carefully, because that's our key investment. And I welcome the creation of capacity, the creation of additional capacity in the Department of Health and the HSE to look at the whole issues around workforce planning, because I think we need to think very carefully about how we motivate and retain people, and it's not just a matter of salary. But I'll take that first question. Anyone want to take the second one? Poison chalice.
The second one being in relation to the costs versus the vision, and what progress has been made. I think that's what you were asking. In a way, I think we're only at the starting line now, even though, Bernard, you began on the committee in June 2016, that in a way the appointment of Laura McGahey and the setting up the implementation office is the starting line. Been slow to get here, but we've got here. And in terms of cost versus vision, I think Steve's presentation earlier of the slides shows that it is doable. It is doable. It will require more money, but it's doable. But in order to do it, there has to be that political will to fund making it happen.
Yeah, I would just add the point of doing the revised costings is to take account of the realities of fiscal space and the absolutely important demands and needs in some of the other sectors. So what we're saying is that we can still keep hold of the vision and the integrity of that, but maybe phase it in a slightly different way that makes it more realistic within budgetary constraints.
Last question, Chairman. Are you satisfied that I have a thing about waiting lists? Everything becomes a waiting list in this country at the present time. Not only this country, but everywhere, as far as I can see. And the thing about waiting lists is this: if it is possible to deal with the issue on the first day, or even the second day, or even the 20th day, that eliminates that waiting list building up. Whatever it's for, whether it be housing, whether it be health services, whatever the case may be. But there's already a long waiting list there, and we have to deal with that somehow. And if we are waiting to deal with the long waiting list that is there in the first place, and at the same time put in place the structures that we all recognise are envisaged, how will that work out? And have we paid sufficient attention to those long waiting lists? And I know that the treat for purchase scheme has dealt with some of it, but unless we get to a stage where it's manageable, down to the last 2 months or whatever the case may be, how quickly can we get to that? Will it be in 4 years, 10 years, 12 years, 20 years? Once we get into that amorphous mass and disappointment to the patient, and the patient in severe pain, for example. And I put down all questions over the years, and you know, a patient who was already in severe hip replacement or something like that, in very severe pain, and maybe an elderly patient, and at the same time getting the reply which says, you know, it'll take X number of years for the patient, or come back in X number of years. So many times we get that, Chairman, in dealing with the services that are vital services nowadays, and it seems to affect this country more than anywhere else. My question is this: the holding of the line and starting somewhere and saying we're intervening now and this is where it's going to be from here on in, and at the same time dealing with the long queue that's at the other side of that line and ensuring that it doesn't build up again.
I think, to respond to that, I mean, you say that the problem is bad in other countries too. Well, actually, it probably isn't. I think Ireland is well out of line with international practice. Certainly, with international best practice, we have some of the longest waiting times, I think, in Europe. So I would. And
why do we have that when we still spend higher than average amongst the OECD countries? Well, higher than average.
Well, I think that's an interesting debate. I'm not sure we spend the money that well in some cases. We also push back some expenditures onto the private sector. I think our incentive structures mean we have often quite a lot of dual practice, and that can create problems through the different incentives. But I want to come back to the issue about how you manage this problem, because I actually don't think we have very good information on it in terms of waiting times. We don't really have very good waiting time data. We have waiting list data. And I think getting much better information out there, much more detailed information on different waiting times for different procedures in different parts of the country, making that publicly available, that suddenly starts for people then can be empowered to actually start to do something about it, and politicians can be empowered to do that. I think whilst it's hidden, whilst we have a problem and it's hidden behind bad data, it's much more difficult to do something and say, well, where is the problem? And I think what Sláintecare does is important investment in e-health, in some of these data systems. And I think once the actual truth starts to come out, it's much easier to be able to manage it better.
And just very quickly on that, Margaret, can I come in? We talked about this before at the committee, Bernard, and I think Sarah Barry, our colleague, talked about the spinning wheels, and I think what we've got to do is both. We have to bring down the waiting times. They're absolutely unacceptable and inhumane the way they are at the moment. But you also have to reform the system so that you're addressing the people who are currently waiting a long time, but you've got to start having diagnostics in the community, same-day access to GPs for tests that they need, quicker elective care, much more stuff outside a hospital. And once you get that moving, then that can stop the build-up that's happening now. But it's not an either-or. You have to do both.
Thank you very much. Sarah. Senator Burke. Sorry, Bridget.
Yeah, so along the same points being made there, Sláintecare is very clear about this model of integrated care and moving care away from the places of highest complexity into the most appropriate setting for their care. And this shift away from lists of people waiting to see somebody in an outpatient clinic in a hospital and being able to meet needs in the community more often. So what we're seeing is a lot of pent-up demand, a huge amount of demand that we're not able to measure appropriately because we don't have the full numbers on individuals. Some of these people are repeated within several lists. But this demand is essentially often being channeled into the wrong streams, into the wrong pots. They belong in other places. So you need both. You need the resources to get people into the right places that can meet that capacity and move them away from thinking of this, how can we make the system we have now better? How can we have a better system that will do things much more efficiently than we've been doing them so far?
Thank you very much, Bridget. Senator Burke.
I just want to thank you very much for your presentations, and my apologies, I had a commitment for another matter earlier on, so my apologies for being late. Just in relation to efficiencies within the HSE at the moment and within the health service at the moment, and you talked about medication, and you talk about access to GPs, and you take, say, for instance, simple example, the cost of drugs and pharmaceuticals in this country, and on the one hand, while people are getting the drugs and pharmaceuticals, in a lot of cases they're not being used. People don't necessarily use them. For instance, the other issue is in relation to the use of generic drugs, where we tried to bring in some changes in that. It has brought about some change, but there hasn't really been a huge savings in monies. So, on the one hand, we're talking about pouring money into the health service, but one of the things that we're not looking at is where can we create efficiencies. And you're talking about free access to GPs. One of the big complaints that GPs have, for instance, is when we brought in the scheme for, and it's a very welcome scheme for the under sixes, the big complaint that GPs have is the number of unnecessary visits that they're now having to accommodate. And likewise, the issue is that you increase the amount of free access, whether it is in relation to pharmaceuticals, whether it is in relation to GPs, then the question is, how do you make that service efficient and that it's not a case of unnecessary use by people? So I'm not clear that we've looked at that issue. The other issue in relation to our hospital structure and about efficiencies and about why, and I'm dealing with quite a lot of people who are working in the medical care sector, and I find now that within the HSE there's a huge problem with morale by nursing staff, by doctors, by junior doctors, by consultants, to such an extent now, for instance, I find there's a lot more people now retiring earlier than what they had planned because they just want to get out. The pressures that are now being put on people right across the board, and as a result their view now is that they want to get out, and they're getting out 3, 4, 5 years earlier than what they had planned, which is now going to create its own problems within the healthcare sector as well. And just on the issue of consultants, if we want to deal with waiting lists, we have to have a lot more people in there who have the ability to deal with the lists in a timely manner and at the same time have the backup support. Yet if you look at the HSE over the last 3 to 4 years, we've taken on over an extra 12,000 people. And I'm not sure whether there was an overall plan to see exactly where did we need people and what did we need to prioritise. It appeared to have been a hit and miss. It was a case of who could shout loudest for extra staff appeared to have got them. So I'm a bit concerned that we're talking about putting more money into this service, into the health service, without actually necessarily saying, well, okay, let's look at it from 1 to 10. Where do we need to start in relation to staffing, and where do we need to prioritise in order to deal with the inefficiencies there? The other issue that I have within the health service at the moment is lack of accountability, and we did the patient safety bill last week, and I raised this very issue, that here we're talking about the patient safety bill, and we're talking about accountability, but in particular it's aimed at medical practitioners and nursing staff. But we're not, I am not satisfied that we have any mechanism within the current structure of the HSE, and it's not even referred to, I may be wrong on this, within the Sláintecare report about accountability of managerial staff to the extent that we need. And I'm a bit concerned about that. And there is another issue as well, and this is what's causing huge inefficiencies in health service. This moving of the deck chairs within the HSE management, where, and I've kept bringing up this issue, one hospital that I know has had 10 hospital managers in 18 years. 10. And the lack of continuity in that process. But no one has actually said, well, why are people moving? Is there a problem with the job? Is there a problem with pay? No one has actually looked at that. And their issues and this whole issue of moving the deck chairs within management and administration, where people are in a job for 12 months, then to move on to another job 12 months later. Whereas if you go in as a nurse, you're more than likely going to be in a particular area for a period of time. Likewise with the medical staff. So you're there is continuity, but we don't have that continuity, and I don't see us having examined that whole management structure at all in relation to rolling out this long-term plan and this whole issue about accountability. And I'm just wondering how you would deal with that. And finally, can I just go back to the graph that was raised earlier about the duplication of where people have medical cards and have health insurance, and then there is a group of people that have neither a medical card nor they don't have health insurance. I'm just wondering what are the exact percentages on that, because I actually think I missed that, the various percentages on that, but I think it would be helpful if I could have those percentages. But again, thank you for your contribution.
Thank you.
Yes, thank you, Senator. I don't share all your concerns about efficiency, but I hear them. I think in Sláintecare there's actually quite a large focus on changing the current inefficient system to one that is much more efficient. And I think my worry is that if we just allow the system to persist as is, then the inefficiencies persist as well. So if you actually look at what Sláintecare is trying to do, it's moving care from where it's currently provided into lower care settings. So moving care out of acute care settings into primary and community care settings, where it's done much more efficiently and probably quickly and responsively. It's changing the skill mix around the delivery of some care, so we're not so reliant on doctors to provide care. We're looking more at alternative provision of different kinds of care. And I think that the whole free GP and practice nurse access for under 60s is an interesting case in point. I think we need to think creatively about how do we provide that care so that the system is not unnecessarily unburdened, and can we use more practice nurses in that kind of setting? How do we do that? How do we think about that creatively? I think Sláintecare is also about doing things in a low-cost public care setting rather than in a high-cost private care setting. I think interesting data that we presented last week from Eurostat around European healthcare expenditure shows that we are the third most expensive in terms of voluntary health insurance spending per person. We're actually the 12th most expensive in terms of government funding per inhabitant. So actually some of that we've got to be careful not to believe some of the myths that some people put out in terms of we're spending far too much money. Actually, it's usually how we spend it and where we spend it. And Sláintecare is critical about changing the way that is done. Now that requires transition, and that's quite a difficult process and sometimes slightly expensive in the short run, but what it then delivers is a system which operates far more efficiently. So yeah, I think I'll stop there. Any other takers?
And then following on from Professor Thomas there, this idea of efficiency, quite often people say then, well, we have to charge, because if we don't charge, as you raised, Senator, if we don't charge, then people are not using drugs the way they should, or visiting the doctor when they don't need to. The thing is that people don't know necessarily when they need care, so it's better for them to access it and be sure of what's going on. But it's weighing this choice between unnecessary utilizations and making sure people don't go to the GP, don't take a drug they don't need, or fill a prescription they don't use, versus crowding out people who actually need to use care. So we might look to improve efficiency on one end, but what we end up with is a very inefficient outcome in terms of people not accessing care until their problems are quite complex, or accessing them in a scenario that could have been dealt with much earlier. So we have to be careful, because there is no evidence of a sweet spot for charges that somehow eliminate all the unnecessary utilization, but don't keep people from accessing care the way they need to in the most appropriate setting. And we know there's evidence in Ireland that charges prevent people from adhering to their medication, but also keep the poorest and the sickest from visiting their GP. They're a direct deterrent. So it's not necessarily true that introducing charges or maintaining charges or keeping charges at all costs will keep utilisation to only the necessary components. And then again on this free GP access, yes, there has been an increase in demand because of the under 6 and the expansion of care, but there's also a call in Sláintecare for increased primary care capacity, increased GP capacity to meet these needs, but also increased palliative care, increased home care services, so other services to complement those needs. So it's not just up to the GP to be able to, the GP can work with other healthcare professionals in tandem to provide this. And it's important to point out that, going back to the drugs issue, that drugs they're not going to be free under Sláintecare. They're going to be affordable. So for people on medical cards or GP cards or other types of safety net, that they're not paying a charge that we've already deemed they're unable to afford. They've gotten a medical card because they're low income or have a chronic illness and can't afford these. And then for households who have a certain amount of affordability for these drugs, that we're not charging them more than that, and we've pushed the thresholds up over the last number of years to a level that's not sustainable for many households. And I'll leave it at that.
Sorry, just clarify that about pushing.
Yes, I'm sorry, I left that note off in the end. So the percentages actually dropped when we look at the no coverage, and I can't bring it up right now. The amount of households who within that breakdown of looking at the 15% of households who couldn't afford their health care. There we go. So in 2009-10, it was about 13% of households who couldn't afford their health care expenditure. That's both their out-of-pocket charges and their private health insurance premiums. That was 12.2% of those in the yellow. That means they had no coverage. They had neither a medical card or private health insurance. That actually dipped to 9.8% in 2015-16. But this comes with a huge health warning, because what we're really capturing here is a huge amount of unmet need. Most households can't even afford to put themselves into financial hardship. They don't have the money to spend on private care or insurance premiums. And we have good evidence to support that unmet need is growing in Ireland. A recent survey found that we now have the second highest rate of unmet need for health care in the EU, at 40.6% of adults over 15 saying they've had an unmet need for health care in at least the last 12 months due to cost, distance or waiting list. Only Latvia is higher than us now.
Can I just check on the drug issue, but isn't there a cut-off point that people can spend on drugs per month? Isn't there, once you go above, is it 134 euros?
Yes, there is.
Yeah, so like, you know, so there actually hasn't been an increase.
There was in that threshold over a number of years, Senator.
There was
yes.
between 2010 and 2015.
Yes.
Yeah, but that's now dropped.
It's come back down.
Yeah.
Yes.
Okay.
But not all the way.
But not enough to the thresholds where we see that it was more affordable for households.
And I'm not suggesting that there should be an increased cost. All I was asking was the question about how do you create an efficient service where you can deliver the service and you can at the same time make sure that there isn't a unnecessary use of the service, and that came home very much in relation to the introduction of the under 6 free GP care. You know, if we continue to increase free GP care, we also have to meet that challenge as well. So that is the question I'm asking. I'm not asking about increasing costs or anything else and want to reduce costs, but how do you deal with that demand that occurred, like what occurred in the under 6s case?
Yeah, and I think it was quite a useful test case in some ways about how do you change entitlements and then how does the system respond. I think there's probably a lot of learning to be done from that case study. I think thinking quite carefully about what the system capacity looks like, where people are directed into the system to get their care, where you don't necessarily need to go directly to the GP. Could the care be provided by other healthcare professionals? Now, you have to have the system capacity to do that, and that's why Sláintecare invests in that. But I think there's a case in point for there to be appropriate learning from that policy.
And the other one I just want to touch on about community care, and I fully agree with what you have to say on that, but I was speaking to a GP where, you know, primary care centre, and there's now a physiotherapist employed there by the HSE, and for him to get an appointment for a patient with the physiotherapist in the community care centre, it was taking anything up to 6 weeks, whereas he could ring a physiotherapist privately and even appointment within 24 hours. So, you know, if we are, and I fully agree that we need to introduce community care at a far higher level than what we're doing, the question is how do you make sure that you're delivering a service in a timely manner and it's not just about employing people. And that's a challenge as well.
It is.
And could I just make a point in relation to the under-6s? Nobody's arguing about the expansion of free care or care at low cost. But we've seen over the past number of years expansion of free care to under-6s, which is about an extra 240,000 children, I think. There's been an expansion of care to people in receipt of domiciliary care allowance. There's been an expansion of free care to people who have carers allowance. At the same time, we've had a reduction of resources towards the practice of 38%. So when you come back to the under-6s then, what's happened with the under-6s is the visitation rate has increased. The capacity of general practice to deal with that visitation rate is not there. Those under-6s end up going to out-of-hours services. The capacity in the out-of-hours service to deliver that free care is not there. So people end up in casualty. And the presentation of under-6s in accident and emergency departments has gone up since the provision of free GP care for under-6s. It's not that children have got any sicker in that period of time, but because they have a free entitlement, if they don't get it in general practice or out of hours, they're going to present to the A&E departments. So you can expand entitlement, but unless you match it with an expansion of capacity, then it has that type of consequence, which doesn't make any sense. Why would an A&E department be seeing more under-6s? Because they have free entitlement. And that's the reason, because general practice didn't have the capacity to take it on. So that's where policy doesn't match the practicality. Just before we do finish up, I'd just like to ask your comments. What we have in the Sláintecare implementation strategy is a translation of Sláintecare into an implementation strategy. And we have touched on some aspects. For instance, lost in translation, as I would put it, is the funding element. Lost in translation is entitlement versus eligibility and the blurring of that there. I think there's also been a loss of urgency, because I don't get an impression of urgency from the Sláintecare implementation strategy. And we're now 2.5 years into the whole process from starting Sláintecare to where we are today. And we still haven't seen any policy change. So are there other areas that have been lost in translation that you can identify? Very broad question.
Well, as to the one that we've been talking about, which is ensuring that there are more healthcare professionals in that primary and community care setting. I mean, Sláintecare looks at expanding around, I think it's probably 5,000 addition, well, 6,000 in the entirety, but this is 5,000 or so around occupational therapists, public health nurses, and making sure that that's there. I don't see any indication that that's been taken on board, and unless you have that staffing of that broader primary and community care setting and social care setting, then actually that's the critical component that unlocks so much else. If you want to move care out of the acute care setting, that has to be a priority. I don't see it being picked up.
Okay, thank you.
An interesting issue there on that graph, a breakdown of the income categories in for instance, the medical and GP card coverage between full medical card and just GP card. Well, interesting to see the proportions of each and the income categories, and also the income categories covered in the entire graph. I think would be
just
interesting.
a health warning with this, Deputy, is that this is just the proportion of the population experiencing financial hardship. So it's 14 or 16%. It's not the whole population, but certainly we can send you those figures for the whole population. Yeah.
And the household budget survey has its own limitations in terms of the type of data it's providing. It doesn't go into residential care settings, so we're not capturing some of the people who would be living in nursing homes or other residential settings. Is one of the limitations of the household budget survey. But it is a beginning look, which nobody's done before, at how affordable is the kind of spending that we're asking households to incur.
Thank you.
Deputy Durkan, thank you. So, in conclusion, I'd like to thank you for coming in at short notice. Dr. Sarah Burke, Professor Steve Thomas and Dr. Bridget Johnson, thank you very much for your input into the Sláintecare process and into the analysis of the outturn of it so far. I'm sure we'll be meeting again. Thank you very much.
Thanks, Mike.
As that concludes our business, we are adjourning this meeting until next Wednesday morning at 9 o'clock, when Dr. Gabriel Scally will come to discuss the scoping inquiry which he conducted into cervical screening.